Hello, it's Dmitry, and today we'll be reading again from the First Aid for the USMLE Step 1 textbook, the 2025 edition. And the book you see in front of you on the screen is the 2017 edition. So you can either refer to the one on the screen or just hear what I'm saying necessarily, or you could look at some other edition that you have in front of you. We'll be continuing back where we were before on the cardiovascular chapter, back now starting on the pathology section thereof. So, let's begin. Cardiovascular pathology, congenital heart disease, right to left shunts, early cyanosis, blue babies, often diagnosed prenatally or become evident immediately after birth, usually require urgent surgical treatment and or maintenance of a PDA via prostaglandin therapy. The 5 T's: truncosarteriosis, 1 vessel; 2, transposition, 2 switched vessels; 3, tricuspid atresia, 3, stri; tetralogy of flow, 4, tetra; and then 5, is that TAPVR, so tapper? I'm not quite sure how you pronounce that. 5 letters in the name. Okay, so it's just kind of like a way to remember it. 1 vessel, 2 switch vessels, tri, tetra, 5 letters in the name. Persistent truncosarteriosis. Truncosarteriosis fails to divide into pulmonary trunk and aorta due to failure of the aorticopulmonary septum formation. Most patients have accompanying VSD. D-transposition of the great vessels. When they say D-transposition, they mean dextro. D is in dextro. Dextro as in right. So you have levo, which is left, and then dextro, which is right. So when they say the same thing when they say anything else, when they talk about certain chemical or certain molecules, where they say there's a D or an L in front of it, that might indicate for you that's referring to a particular configuration. So D, transposition of great arteries. Aorta leaves RV, right ventricle, anterior, and the pulmonary trunk leaves the left ventricle, posterior. Separation of the systemic and pulmonary circulations. Not compatible with life unless a shunt is present to allow mixing of blood, for example, a VSD, or a PDA, or a patent foramen Due to failure of the aorticopulmonary septum to spiral, narrow superior mediastinum causes egg on a string appearance on chest x-ray. Without surgical intervention, most infants die within the first few months of life. And you can see the heart right there as well, showing the left ventricle, the right ventricle, pulmonary artery, aorta, that kind of thing. So that's an example of a heart where they've been flipped. So now the aorta is coming out of the right ventricle, and now the pulmonary artery is coming out of the left ventricle. So that's kind of an inversion essentially. Tricuspid atresia. Absence of tricuspid valve, hypoplastic right ventricle, requires both ASD and VSD/PDA for viability. EKG shows hypertrophy of right atria, tall P waves, and left ventricle with left axis deviation. Tetralogy of flow. Caused by anterosuperior displacement of the infundibular septum, most common cause of early childhood cyanosis. 1. Pulmonary infundibular stenosis, most important determinant for prognosis. 2. Right ventricular hypertrophy, RVH, boot-shaped heart on the chest x-ray. That's a very key thing to see. 3. Overriding aorta, straddles VSD, receives blood from both the left ventricle and the right ventricle. And then finally, the VSD, the ventricular septal defect. And so the reason they call it, again, tetralogy of flow is because there's 4 different things that are going wrong at the same time. Pulmonary stenosis forces a right to left flow across the VSD, causing right ventricular hypertrophy. TET spells, often caused by crying, fever, and exercise due to exacerbation of the right ventricular outflow obstruction. PROV, this is a mnemonic, PROV, P-R-O-V. Squatting increases the systemic SVR. What would that be? I want to make sure that I'm not saying this incorrectly. SVR medical abbreviation would be the systemic vascular resistance. Resistance is one, okay. So squatting increases the systemic vascular resistance, causes a decrease in right to left shunt, and improves cyanosis associated with the 22q11 syndrome. So they're saying that this condition of tetralogy flow is associated with this kind of syndrome, 22q11, which is a mutation. And again, you can see the heart right there, showing the 1, the 2, the 3. So the 1 that they're showing, I believe, is the overriding aorta. The 2 they're showing is the right ventricular hypertrophy. The 3 they're showing, oh no, I might have I think I confused this too. So 1 is the pulmonary stenosis. 1 is the pulmonary stenosis. 2 is the right ventricular hypertrophy. 3 is the overriding aorta. 4 is that VSD, right? You can see that that's septal defect right there. What about total anomalous pulmonary venous return? Pulmonary veins drain into the right heart circulation, SVC, coronary sinus, etc. The superior vena cava, coronary sinus, etc. Associated with the ASD, atrial septal defect, and sometimes a patent ductus arteriosus, to allow for the right to left shunting to maintain cardiac output. Epstein anomaly. Displacement of tricuspid valve leaflets downward into the right ventricle, artificially atrializing the ventricle, associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. Rare, can be caused by lithium exposure in utero. Now on to the next page. We're talking about left to right shunts. So we just talked about right to left shunts before, going from the right to the left. Now we're talking about a shift from the left to the right. What's going on with that? Well, left to right shunts, acyanotic at presentation, cyanosis may occur years later, frequency VSD is greatest, then ASD, and then PDA. Right to left shunts are early cyanosis. Left to right shunts are later cyanosis. So they say, okay, if you could see, oh, the early RL is in that order, left to right, LR, later, right? So basically, when you have certain kinds of heart conditions, you might have a transition from a right to left shunt that eventually becomes a right to left shunt, which eventually becomes a left to right shunt. It switches over time, and that's because of things like, let's say, for example, hypertrophy of the ventricles, which causes a shift from, again, right to left initially to a left to right later on. Because your body's trying to compensate for what's going on, and eventually it can cause a reverse in flow. So what about a ventricular septal defect, a VSD? Asymptomatic at birth, may manifest weeks later, or remain asymptomatic throughout life. Most smaller defects self-resolve. Larger defects, if left surgically untreated, can cause an increase in pulmonary blood flow and left ventricular overload, Eisenmenger syndrome, which may progress to heart failure. O2 saturation increases in right ventricle and pulmonary artery. Atrial septal defect, ASD. Defect in intraatrial septum, which is shown in the picture B. Systolic ejection murmur with wide, fixed splits, S2. Ostium secundum defects most common and usually an isolated finding. Ostium primum defects rarer and usually occur with other cardiac anomalies. Symptoms range from none to heart failure, distinct from patent foraminal which is due to a failed fusion. So it's not the same thing. O2 saturation increases in right atrial and right ventricle, and the pulmonary artery as well. May lead to paradoxical emboli. Systemic venous emboli use ASD to bypass the lungs and become systemic arterial emboli in the setting of temporary shunt reversal, for example, when lifting weights or an Eisenmenger syndrome associated with Down syndrome. That's true. So the reason why it's kind of an issue is not simply because in and of itself it's a problem, which, I mean, sure, it's not great, but it can also cause certain kinds of emboli, which would otherwise, go from the right atrium to the right ventricle into the pulmonary artery, distributed across the lungs, and they get caught somewhere in the lungs, which is, again, not great. It's not good. But if it just bypasses the lungs entirely and it goes from the right atria to the left atria, and then from left atria to left ventricle into the systemic circulation, it could cause something like a problem in the brain or something like that. So it could lead to something significantly worse if it can just bypass the lungs. Because the lungs are basically serving as, even though they're not, maybe not intentional, the lungs are serving as a kind of filter. So if you have an emboli that's going on, it's preventing that embolus from going into the systemic circulation, like in the brain or something like that. It's more serious because everything has to go through the heart, and if everything has to go through the heart, then everything has to go through the lungs. Make sense? Patent ductus arteriosus, PDA. In fetal period, shunt is right to left, normal, but in the neonatal period, decrease in pulmonary vascular resistance leads to a shunt and becomes left to right, leading to progressive right ventricular hypertrophy and or left ventricular hypertrophy and heart failure. Associated with continuous machine-like murmur, important to know, patency is maintained by prostaglandin E synthesis and low O2 tension. Uncorrected PDA can eventually result in late cyanosis in the lower extremities, differential cyanosis. PDA is normal in utero and normally closes soon after birth, though. So basically what's going on in a PDA is that the blood from the aorta, because now your left ventricle has become dominant and the aorta is pumping lots of blood into the systemic circulation, some of that blood's actually going into now into the pulmonary artery, and so it's causing problems like that. So something to be aware of. Eisenmenger syndrome. Uncorrected left to right shunt, VSD, ASD, PDA, leading to an increase in pulmonary blood flow, leading to pathologic remodeling of vasculature, leading to pulmonary arterial hypertension. Right ventricular hypertrophy occurs to compensate for. Sorry, let me read it again. Right ventricular hypertrophy occurs to compensate, leading to a shunt which becomes right to left when the right ventricle is greater than the left ventricle pressure. See the illustration, which is the illustration you can see right there as well. Mine's a little bit different, but it communicates the same idea. It causes late cyanosis, clubbing, and polycythemia. Age of onset varies depending on the size and severity of initial left or right shunt. So basically, Eisenmenger syndrome is not necessarily its own independent pathology with a completely unrelated origin. It is caused by a VSD or ASD or PDA, which eventually progresses into an Eisenmenger syndrome. And now on to correctation of the aorta. Aortic narrowing, as you can see in the diagram there, near insertion of the ductus arteriosus, juxtaductal, associated with bicuspid aortic valve, other heart defects, and Turner syndrome. Hypertension in upper extremities, cyanosis, claudication, coolness, and weak delayed pulses, branchiofemoral delay, in lower extremities. With age, intercostal arteries enlarge due to collateral circulation, leading to rib notching on X-ray. Complications include heart failure, increased risk of cerebral hemorrhage, barrianeurysms, aortic rupture, and infective endocarditis. So it's kind of a persistent pulmonary hypertension of the newborn. So I'm not quite sure where I can find that one. It might not be in here. It might just be a new section they added in at some point since 2017. Let's talk about it. Persistent pulmonary hypertension of the newborn. Persistence of the increased pulmonary vascular resistance after birth associated with abnormal development and postpartum adaptation of pulmonary vasculature. Risk factors include aspiration of meconium-stained amniotic fluid and neonatal pneumonia. Leads to right to left shunt through foramen ovale and ductus arteriosus. Preductal O2 saturation is often greater than the postductal. Newborn presents with signs of respiratory distress, for example, tachypnea, and often differential cyanosis. Equal pulses, there's no delay. What about congenital cardiac defect associations again? That's right here. So congenital cardiac defect associations, the association and the defect. So association. Prenatal alcohol exposure, fetal alcohol syndrome. Defect, VSD, PDA, ASD, tetralogy of Fallot. Fair enough. Congenital rubella. Defect, PDA, pulmonary artery stenosis, septal defects. Down syndrome. AVSD, VSD, ASD. Okay. Infant of patient with diabetes during pregnancy. So, like, I guess that would be gestational diabetes. Mother is diabetic. Well, no, gestational diabetes is different. So, ignore that. They're talking about a pregnant mother with diabetes. So, what's the association for the infant? Transposition of great vessels. Kind of crazy. Marfan syndrome, associated with the mitral valve prolapse, thoracic aortic aneurysm / dissection, and aortic regurgitation. And that just kind of makes sense if you think about it. Like Marfan syndrome, think about what's the fundamental issue of Marfan syndrome, what's the other kinds of presentation. You're going to have these issues where it's really just kind of, it's not really able to maintain its proper shape. And so as a consequence, you're having mitral valve prolapse, you're having a thoracic aortic aneurysm or / dissection, right? You're having aortic regurgitation because it's basically, let me just find the best way to phrase. Let me go look it up, just make sure that I'm not mischaracterizing it. Marfan syndrome cause. So basically, it's an issue with fibrilin 1. Okay, so it's elastic fibers, exactly. So it's not able to properly maintain shape. Okay. Now, prenatal lithium exposure causes Epstein anomaly. Turner syndrome causes bicuspid aortic valve, aortic coarctation / dissection. Williams syndrome causes supravalvular aortic stenosis. 22q11 syndromes, truncus arteriosus and tetralogy of Fallot. So again, truncus arteriosus and tetralogy of Fallot, sorry. And I want to make sure that there's more to it than that. So when they have a question stem, it says, oh, we have this 22, this condition which is 22q11. It's not going to simply be heart issues. There's also going to be some other problems as well. So 22q11 deletion, which is DeGeorge syndrome, basically, also called velocardiofacial syndrome, presents with highly variable spectrum of symptoms that often affect multiple organ systems. Key features include the congenital heart defects, palatal abnormalities, immune system deficiencies, hypocalcemia. Is this the one that's the issue with the, you have thymic aplasia? Is that correct? We have issues with hypocalcemic, probably because you have low PTH, because there's something wrong with the PTH, the parathyroid glands. So the parathyroid glands are kind of underdeveloped. Yeah, you have thymic hypoplasia, so you have low T cell count, so you have a defective immune system. So that's all DeGeorge syndrome. So they're saying here, if you have a 22q11 problem, you might have truncus arteriosus and tetralogy of Fallot. That's true, but when you actually get a question stem, it's not going to be just that. It's going to be these other problems as well. And it's also called DeGeorge syndrome for reference, if you want to look more into it. Hypertension. Persistent systolic blood pressure is greater than 130 mmHg and or diastolic blood pressure is greater than 80 mmHg. And if I were you, I would just look up the kind of chart that they have available online that shows you, 140 versus 120 versus whatever, that kind of thing. It tells you when is it normal, when is it elevated, when is it type 1 hypertension versus type 2 hypertension versus hypertensive crisis. So risk factors for hypertension: increase in age, obesity, diabetes, physical inactivity, high sodium diet, excess alcohol intake, tobacco smoking, family history, incidence greatest in Black, greater than white, greater than Asian populations. 90% of hypertension is primary, which is to say essential, and related to the increase in cardiac output or increase in total peripheral resistance. The remaining 10% is mostly secondary to renal or renal vascular diseases such as fibromuscular dysplasia characterized by a string of beads, appearance of renal artery, as you can see in that picture right there. usually seen in adult females, and atherosclerotic renal artery stenosis, primary hyperaldosteronism, or obstructive sleep apnea. Hypertensive urgency, severe, greater than, yeah, that's what I was talking about before. Hypertensive urgency, which is greater than 180 / greater than 120, so that's the systolic and the diastolic, MMHG. Hypertension without acute and organ damage. So basically, hypertensive urgency is just telling you, oh, you have a really, really, really high blood pressure. It doesn't necessarily whether or not there's been any sort of consequences of that in terms of organ damage yet. But a hypertensive emergency, though, is severe hypertension with evidence of acute and organ damage. For example, encephalopathy, stroke, retinal hemorrhages and exudates, papilledema, myocardial infarction, heart failure, aortic dissection, kidney injury, microangiopathic hemolytic anemia, and eclampsia. Arterioles may show fibrinoid necrosis. Okay. This predisposes to hypertension overall, predisposes to coronary artery disease, concentric left ventricular hypertrophy, mediated by angiotensin II and endothelin, heart failure, atrial fibrillation, aortic dissection / aneurysm, stroke, chronic kidney disease, which is a hypertensive nephropathy, and retinopathy. Hyperlipidemia signs. Plaques or nodules composed of lipid-laden histiocytes in skin, which you can see in the picture there, especially the eyelids, xanthelasma, which is seen in the picture B right there. Tendinous xanthoma, lipid deposit in tendon, as you can see in picture C, especially Achilles tendon and finger extensors, associated with familial hypercholesterolemia. Corneal arcus, lipid deposit in cornea, common in older adults, arcus senilis, shown in picture D, but appears earlier in life with hypercholesterolemia. Atherosclerosis. Very common form of arteriosclerosis, hardening of arteries, disease of elastic arteries in large and medium-sized muscular arteries, caused by buildup of cholesterol plaques in tunica intima. Location. Abdominal aorta, greater than the coronary artery, which is greater than the popliteal artery, which is greater than the carotid artery, greater than the circle of Willis, a copycat named Willis. So again, abdominal aorta, coronary artery, popliteal artery, carotid artery. A copycat named Willis. Okay, sure. Risk factors for atherosclerosis. Well, my section shows arteriosclerosis. So did they add a section on atherosclerosis later on? Yeah, here we go. Right here. Let me focus on this right now. Risk factors. Modifiable hypertension. So modifiable risk factors would be hypertension, tobacco, smoking, dyslipidemia, which increases the LDL and decreases HDL, and diabetes. So these are the things you can kind of modify, basically. What about non-modifiable? Age, male sex, postmenopausal status, and family history. What are some symptoms? Angina, claudication, but can be asymptomatic. Progression. Inflammation important in pathogenesis, endothelial cell dysfunction, macrophage and ADL accumulation leading to a foam cell formation, which leads to fatty streaks, leading to smooth muscle cell migration, involves PDGF and FGF, proliferation, and extracellular matrix deposition, which leads to fibrous plaque, which leads to a complex atheroma, which is shown in picture A in my book, but I'm not sure if you have that in yours. Yeah, it's a picture B for you. This leads to calcification. Calcium content correlates with risk of complications. So what are the complications? Ischemia, infarction, aneurysm formation, peripheral vascular disease, thrombosis, embolism, renal vascular hypertension, coarctation of the aorta, and subclavian steal syndrome. I have a little diagram that shows as well this sort of normal artery, whereas endothelium, smooth muscle, and then endothelial dysfunction occurs where you have the monocytes popping up, you have some damaged endothelium, and then later on you have a fatty streak formation that happens. We have LDL-laden macrophage. The fatty streak is present. The foam cells are popping up, right? The macrophages are eating it up, and so they're becoming foam cells. And then you have finally the fibrous plaque formation, where now you have the endothelium, which is now overlaying the plaque, or trying to at least. And you have these smooth muscle cells kind of inside the giant plaque. It's all this fat in the plaque. There's smooth muscle migration, right, coming out into the plaque. And the plaque is fibrous. And so you can see in that picture, though, that huge plaque that popped up and how the vessel has become much smaller, or the radius that it can flow through is much smaller than it was originally. And that's just like a combination of smooth muscle cells, fat, foam cells, all the above, right? But the implication is that it starts off as sort of an issue of damage to the endothelium, and then fat starts building up, right? And then eventually they start forming these foam cells and start having smooth muscle migration. So it sort of kind of gets worse and worse and worse, basically. What about aortic aneurysm? Or what about cholesterol emboli syndrome, which is the next thing that I have in my book? Cholesterol emboli syndrome, microembolization, so forth. I'm going to see if they have that in here as well. Maybe not. Okay. Let me just go back to arteriosclerosis. Nope, not mentioned. So, cholesterol emboli syndrome, microembolization of cholesterol displaced from atherosclerotic plaques, which is shown in the picture that I have in my book, but you cannot see it, so you just have to look it up. In large arteries, usually the aorta, results in end organ damage due to small artery emboli and an inflammatory response. That is to say, livedo-reticularis, digital ischemia, Bluetooth syndrome, acute renal failure, cerebrovascular accident, gut ischemia. Pulses remain palpable because of larger arteries are unaffected. May follow invasive vascular procedures, angiography, angioplasty, endovascular grafting. Arteriosclerosis. Common form of arteriosclerosis affects small arteries and arterioles, two types: hyaline, vessel wall thickening secondary to plasma protein leak into the subendothelium in the hypertension or diabetes mellitus, which is shown in the picture A. Yep. Or hyperplastic or onion skinning, which is shown in picture B, and severe hypertension with proliferation of smooth muscle cells. And your book also has something on it talking about Monkberg sclerosis. I don't see that in my book, but I can read it out for you anyways. Uncommon, so medial calcific sclerosis, Monkberg sclerosis. Uncommon, affects medium-sized arteries, calcification of internal elastic lamina and media of arteries leading to vascular stiffening without obstruction. Pipe stem appearance on X-ray as shown in the picture C. It does not obstruct blood flow. Intima is not involved. Now on to aortic aneurysm. Aortic aneurysm, localized pathologic dilation of the aorta, may cause abdominal and or back pain, which is a sign of leaking, dissection, or imminent rupture. Thoracic aortic aneurysm. Associated with the cystic medial degeneration, risk factors include hypertension, bicuspid aortic valve, connective tissue disease, for example, Marfan syndrome. Also associated with tertiary syphilis, obliterative endarteritis of the vasa vasorum, aortic root dilation may lead to aortic valve regurgitation. Abdominal aortic aneurysm. Associated with transmural, all three layers, inflammation, and extracellular matrix degradation. Risk factors include tobacco smoking, strongest risk factor, increase in age, male sex, family history. May present as a palpable pulsatile abdominal mass, which is shown in the arrows in A. Point to outer dilated aortic wall. Rupture may present as a triad of pulsatile abdominal mass, acute abdominal/back pain, and resistant hypotension, most often infrarenal, distribution of vasovasorum is reduced. Now on to traumatic aortic rupture. Due to trauma and or deceleration and injury, MVA or significant fall, so MVA, motor vehicle accident, I believe, right, or significant fall, most commonly an aortic isthmus, proximal descending aorta just distal to the origin of the left subclavian artery, X-ray may reveal widened mediastinum. Aortic dissection. Longitudinal intimal tear forming a false lumen, associated with hypertension, strongest risk factor, bicuspid aortic valve, inherited connective tissue disorder, that is to say, Marfan syndrome, can present with tearing, sudden onset chest pain radiating to the back, plus or minus markedly unequal blood pressure in arms. Chest X-ray can show mediastinal widening, can result in organ ischemia, embolic stroke, aortic rupture, death. Stanford type A, proximal, involves the ascending aorta, which is shown in the red arrow in my book, but not shown in your book at all, unfortunately. So Stanford type A involves ascending aorta, may extend in aortic arch or descending aorta, may result in acute aortic regurgitation or cardiac tamponade. Treatment would be surgery in that case. What about Stanford type B? Distal. Involves only the descending aorta, below the left subclavian artery. You treat with beta blockers, then vasodilators. So remember, B you treat with beta blockers, and it's distal. A is ascending aorta, and you treat with surgery. Now we're going to be talking about subclavian steal syndrome, which I don't know if it's mentioned in here, so if it's not, I'll just have to read it off. So subclavian steal syndrome. Stenosis of subclavian artery proximal to the origin of the vertebral artery, which leads to hypoperfusion distal to the stenosis. This leads to reverse blood flow in ipsilateral vertebral artery, leading to reduced cerebral perfusion on exertion of affected arm. Causes arm ischemia, pain, paresthesia, vertebrobasilar insufficiency, dizziness, vertigo, greater than 15 millimeter mmHg difference in systolic blood pressure between the arms. Associated with atherosclerosis, most common cause, Takayasu arteritis, and heart surgery. So when you're taking blood pressure, for example, and you see there's this gap between the left arm and the right arm, maybe you think about something like subclavian steal syndrome. Now we're going to be going on to coronary artery disease. Well, coronary steal syndrome is right there, is in that category of things. So your book says ischemic heart disease manifestations. Mine says coronary artery disease. Well, mine actually says ischemic heart disease manifestations lower down. This talks about coronary steal. Oh, that's what that's talking about. Coronary steal, sudden cardiac death, that kind of stuff. But I also have a section on coronary artery disease about angina, MI, that kind of thing. Is that mentioned here? I'm not sure. Regardless, I'm going to go take a short break. Okay. Coronary artery disease. Angina. Chest pain due to ischemic myocardium secondary to coronary artery narrowing or spasm. No necrosis. Stable, usually secondary to atherosclerosis, greater than 70% occlusion. Exertional chest pain in classic distribution, resolving with rest or nitroglycerin. Unstable. Thrombosis with incomplete coronary artery occlusion, leading to an increase in frequency or intensity of exertional chest pain or any chest pain at rest. No cardiac biomarker elevation versus the non-ST segment elevation MI, which is NSTEMI. Vasospastic, formerly Prinzmetal angina or variant. Occurs at rest secondary to coronary artery spasm, transient ischemic ST changes on EKG. Tobacco smoking is a major risk factor. Triggers included cocaine, amphetamines, alcohol, triptans. Treat with calcium channel blockers, nitrates, and smoking cessation, if applicable. Myocardial infarction. Most often due to an acute coronary syndrome, ACS. Rupture of coronary artery atherosclerotic plaque leading to an acute thrombosis. Let me just get the picture right here so you can see it. MI can also occur with prolonged supply-demand mismatch, that is to say, stable angina, leading to a prolonged tachycardia and hypotension from pneumonia, leading to an elevated troponin but no acute plaque rupture. So now we have a little diagram in my book, but it doesn't show it in yours, but you get the idea. You have stable angina, unstable angina, and STEMI and STEMI. So for stable angina, you have a pain on exertion, you have no troponin elevation, there's no infarction, you will see possible ST depression and or T-wave inversion for stable angina. Unstable angina, this is coronary issues, right? Coronary artery disease related problems. Unstable angina. This is all CAD. This is all coronary artery disease. But unstable angina, you have pain on mild exertion or at rest. So you won't necessarily have it just during exertion. You might have it when you're resting as well. That's the difference between stable and unstable. For unstable, you'll have no elevation of troponin, likewise. You'll have no infarction, similarly. And again, you will have possible ST depression and or T-wave inversion. So basically, stable and unstable angina are basically the same thing, except for unstable, you might have problems during rest as well. Okay, now for NSTEMI, so that's non-ST elevated MI. So these are also part of coronary artery disease. That's a kind of it, I suppose, a type of it. But now we're talking about in the category of heart attacks, myocardial infarctions. So NSTEMIs have pain at rest. They have elevated troponin level. They have an infarction that's subendocardial infarction. You can see that in the diagram as well, subendocardial infarction. And they will have ST depression and or T-wave inversion. Okay. And so the important thing is between what distinguishes stable and unstable anginas from the NSTEMI. Well, mainly it's the fact that troponins are now elevated. The actual presentation of, ST depression, T-wave inversion, that's basically similar, right? If there is an EKG change for angina, it will be basically similar to an NSTEMI. The pain during rest for NSTEMI, it's kind of like unstable angina. So there's a lot of overlap in theory. But the big thing is that there's an actual infarction that's happened for NSTEMI, and you actually will have a troponin elevation as a consequence of that. What about STEMI? What about ST elevated myocardial infarction? Well, you will have pain at rest, like an NSTEMI, like an unstable angina for that matter. You will have elevated troponin, like NSTEMI, again, because it's a heart attack going on. You will have transmural infarction. And as a consequence of that, you will have ST elevation and pathologic Q waves, and hence the name ST elevated myocardial infarction. Now here's the thing. Why is it that the the STEMI has a different kind of EKG presentation. It's because of the transmural infarction. So everything that we talked about before, as far as I'm aware, it's all kind of subendocardial basically. It's not full thickness damage. And so when you have angina, or when you have an NSTEMI, certainly an NSTEMI, but when you have angina as well, you're not necessarily causing damage to the full thickness of the wall. It's partial thickness damage. And again, angina is kind of this issue where it comes and goes. It's not necessarily like this issue where you have permanent infarction or anything like that. It's ischemic, right? Yeah, it is a. Let me make sure I'm not saying this incorrectly. I mean, it is basically it is a brief, transient kind of a ischemia that's going on that will cause pain, but it's not necessarily going to cause a meaningful long-term damage in any particular episode. Now, of course, many episodes of NSTEMI, for example, can cause problems long-term, but it's not the same thing as an actual particular infarction event like an NSTEMI would be or a STEMI would be. The big thing that distinguishes STEMI from all these other things is that it's a transmural, full thickness of the wall infarction, and that causes the different in terms of EKG presentation. I.e., now the ST segment is not depressing, now it's elevating. And there's also pathological Q waves that now are present. So bear that in mind. And there's a good diagram in your book you see in the PDF right here that's actually not in mine. But if you want to read an EKG, you can see what I've heard before when I've taken I think a class in this before. They talk about this sort of I think they call it like a fireman's hat, a firefighter's hat for STEMI. But for the NSTEMI, you're going to see that kind of the depression you see because the ST segment is depressed for NSTEMI, but there's a sort of fireman's hat for the ST elevated MI. And let me check something one more just to see if I have anything on it. They say V5. They're saying check V5. When you want to check the EKG for the heart attack, maybe check V5 just to see what's going on with that. So I talked about coronary steel. Did I talk about coronary steel or I talked about something else? I talked about subclavian steel. So let's talk about coronary steel as well. Coronary steel. Oh, is it here? Angina, coronary steel. Here we go. Now we're going into ischemic heart disease manifestations. Coronary steel syndrome. Distal to coronary stenosis, vessels are maximally dilated at baseline to compensate for reduced blood flow. Administration of vasodilators like dipyrimidine, adenosine, regadenoson dilates normal vessels, leading to a decrease in hydrostatic pressure in normal coronary arteries, leading to blood is shunted towards the well-perfused areas. This leads to a decrease in flow to myocardium perfused by stenosed vessels, i.e. the steel. This leads to ischemia of myocardium downstream to pathologically dilated vessels. Vasodilator stress tests rely on differential and flow to detect potential ischemia. Rarely they can cause coronary steel and true ischemia. Vasodilation of healthy vessels steals blood from stenosed vessels. Sudden cardiac death. Unexpected death due to cardiac causes within 1 hour of symptom onset or within 24 hours with no cardiovascular symptoms, most commonly due to lethal ventricular arrhythmias, that is to say, ventricular fibrillation, impairing blood flow to the brain, associated with CAD, coronary artery disease, in up to 70% of cases, cardiomyopathy, hypertrophic dilated, myocarditis, coronary artery anomalies, and hereditary channelopathies, that is to say, long QT syndrome, Brugada syndrome. Prevent with implantable cardioverter defibrillator. Chronic ischemic heart disease. Progressive exertional symptoms and or development of heart failure due to chronic ischemic myocardial damage. Myocardial hibernation. Left ventricular systolic dysfunction in the setting of a chronic ischemia, potentially reversible with myocardial reperfusion, seen in stable angina, acute MI, or heart failure. Contrast with myocardial stunning, transient, reversible left ventricular systolic dysfunction after brief acute ischemia. So that basically just confirms that, you will have sometimes, you will see ischemic issues with a stable angina, even though it's not causing an actual episode of infarction. It could still cause damage to the heart if you have many episodes. It can cause issues, of course. Evolution of myocardial infarction. Commonly occluded coronary arteries, left anterior descending greater than RCA, right coronary artery, greater than the circumflex artery. Symptoms: diaphoresis, nausea, vomiting, severe retroexternal pain, pain in the left arm and or jaw, shortness of breath, fatigue. And so here's a gross image of it, of course, as well. So this is 0 to 24 hours. What happens, as you can see, is that, and that's basically pretty normal looking. You can see the normal, you can see the infarct, okay, whatever. There's a occluded artery right there. Dark, here's the difference. Dark modeling, pale with tetrazolium stain. Okay. Light microscope. So wavy fibers, 0 to 4 hours. Early coagulative necrosis, 4 to 24 hours. Leading to cell content released into blood, edema, hemorrhage, reperfusion injury, which leads to free radicals and increasing calcium influx. That leads to hypercontraction of the myofibrils, dark eosinophilic stripes. So basically what they're saying is that you're going to have a loss of oxygen, okay, and then you'll have reperfusion, which causes a generation of free radicals. This actually causes a hypercontraction because I think the calcium is responsible for the hypercontraction. And that'll cause you to have these dark fibers, these dark eosinophilic stripes on the heart. Complications: ventricular arrhythmia, heart failure, cardiogenic shock. What about 1 to 3 days afterwards? Well, in that case, you can see that it says there hyperemia. It shows extensive coagulative necrosis, tissue surrounding the infarct shows acute inflammation with neutrophils. So be aware when they say something like, what kinds of cells are they talking about? Early on, they're talking about free radicals, eosinophilic stripes, calcium influx, hypercontraction, that kind of stuff. Okay. What about 1 to 3 days? They're talking about what? Neutrophils and inflammation, acute inflammation, neutrophils. Post-infarction fibrinous pericarditis. Okay. That's like potential complications, post-infarction fibrinous pericarditis. Okay, pericarditis. What about 3 to 14 days afterwards? What are we saying? It says here, 3 to 14 days, hyperemic border, central yellow-brown softening. Okay. This is macrophages, then granulation tissue at margins. It says here, what are the complications of this? Free wall rupture, leading to tamponade. Papillary muscle rupture, leading to mitral regurgitation. Interventricular septal rupture due to macrophage-mediated structural degradation, leading to left to right shunt. Left ventricular pseudoaneurysm, risk of rupture. So here's a big thing. So we said before, okay, within the first day, we have eosinophilia, we have reperfusion injury, that kind of thing. Day 1 to 3, we have neutrophils and inflammation that's acute, right? And then day 3 to 14, really the back end of the first week, going into the second week, we have macrophages everywhere, eating up stuff, and that can cause all sorts of ruptures, okay? Makes sense? And then after 2 weeks, we're going to have, it says right there, recanalized artery. I see a gray-white scar even in my book as well. It says here, contracted scar complete. This here shows complications would be post-cardiac injury syndrome, heart failure, arrhythmias, true ventricular aneurysm, risk of mural thrombosis, or mural thrombus. And so for the final stage, after the main sort of process had gone through, now you have this sort of after situation where you have all this scar tissue that's built up, it's gray-white in color, and now you have the possibility that it's not as efficient as it used to be because it's not muscle there anymore, it's all fibrous tissue, it's scar tissue, right? So it's not doing its job like it's supposed to. It can cause this sort of, let me see, it says true ventricular aneurysm. Yeah, it can cause an aneurysm, right? Because it's not the way it's not built the same way, right? You can have a mural thrombus, okay. All that's fair. And your book says Dressler syndrome as well. Dressler syndrome, I think, is also called, I think it's just a different name for the same thing. My book says post-cardiac injury syndrome. I think Dressler syndrome is the same thing. Let me just confirm. So Dressler syndrome is also called, let's see, Dressler syndrome, aka post-myocardial infarction syndrome. So probably the same thing. Dressler syndrome is a more common name. It's been used traditionally, and I guess they're trying to call it here post-cardiac injury syndrome. Either way, it's a condition related to the consequences or the aftermath of having a heart attack, basically. And so let's keep this in mind. So basically, think about it like this. Day one, or first 24 hours, what do we have? Eosinophils. We have neutrophils. We have this stuff going on, right? We have this very early on breakdown, destruction, free radicals, that kind of thing. That's the first 24 hours. The first half of the week, we're going to have these neutrophils hanging around. So first half of the week, we have neutrophils hanging around, okay? The second half of the week, going into the second week, we're going to have macrophages hanging around. That's where you can have issues of like all these sorts of ruptures and stuff like that because they're trying to degrade things and break things down. And then after 2 weeks, you're going to have the final scar tissue presentation. So keep that in mind. When you're talking about a heart attack, when they say a patient had a heart attack 3 days ago, 5 days ago, 2 weeks ago, 5 months ago, whatever, you think about what stage they're in and what things you might see in histology and what kind of complications there might be given the current situation. Diagnosis of myocardial infarction. In the last 6 hours, EKG is the gold standard. In the first 6 hours, EKG is the gold standard. Cardiac troponin 1 rises after 4 hours. Is that right? Or they say troponin I. Yeah, troponin I. Troponin 1 rises after 4 hours, peaks at 24 hours, and is increased for 7 to 10 days. So it's elevated for 7 to 10 days, more specific than other protein markers. CKMB increases after 6 to 12 hours, peaks at 16 to 24 hours, and is predominantly found in myocardium, but can also be released from skeletal muscle. Useful in diagnosing reinfarction following acute MI because the levels return normal after 48 hours. So what they're saying is, let's say for example, a person has, let's say a man is having a heart attack, it's been, let's say, a week, and then he has a second heart attack. No, that's no fun. Well, we can confirm that he had a second heart attack because we could see that his CKMB levels are still very elevated, when if he had a heart attack only a week ago and nothing happened after that, then his CKB level and B levels would actually be low at that point, but the troponin levels would be high in both cases because, again, troponin lasts for 7 to 10 days. And so it's sort of a way to help figure out whether or not you had a second episode of a heart attack within, a few days after your original heart attack. EKG localization of STEMI. Oh, let me go back. Let me wrap this up. EKG changes can include ST elevation, STEMI, transmural infarct, or ST depression with end-STEMI or subendocardial infarct. Hyperacute peaked T waves, T wave inversion, and pathologic Q waves or poor R wave progression, evolving or transmural infarct. Okay. EKG localization of STEMI. So it says this little thing here that says, oh, here's the infarct location, and here's the leads with the ST segment elevators or Q waves. So this is kind of just showing you where would you find each of these things. Where would you find the problem of essentially. Anteroseptal LAD. So if an anteroseptal infarct related to the left anterior descending, where would that be found in the EKG? V1 and V2. And let's say I have an anteroapical infarct because of a distal LAD. Where would I see that? V3 and V4. Let's say, for example, I have an anterolateral infarct related to either the LAD or the left circumflex artery. Where would I find that? At V5 and V6. What if I had a lateral issue? This lateral circumflex issue. What's going on with that? Lateral infarct. Look at EKG for I, or 1, I should say 1, and AVL. Look at those two for that. And then it says inferior RCA, inferior right coronary artery. So if you have an inferior infarction, where would you look for that? 2, 3 AVF. And then finally, posterior. Let's say this would be like an issue for PDA. I think it's posterior descending artery. You look at V7 through V9. There will be an ST depression in V1 and V3 with all tall R waves. So this is a good way to figure out. And I have a little diagram which is useful for me to look at. I will just look it up yourself to see what they're referring to. Look up at an EKG chart and see whether they're referring to, say, V1, V2, V3, V4, that kind of thing. And that'll help kind of piece together exactly what you need to be looking at. And if you see ST elevation somewhere, say, which one is that? Oh, that's V2? Okay, what does that mean? V2, that probably means there's some sort of issue with the anteroseptal region, probably an LAD problem, that kind of thing. Now I'm talking about narrow complex tachycardias. Not sure if it's in here. And then I go into Wolff-Parkinson-White syndrome after I go for narrow complex. So I'm going to see if I can find Wolff-Parkinson-White. Sometimes I'm a little bit frustrated with this, or a little bit annoyed, I should say, because I feel like it should be a little bit more consistent throughout the years. Oh well, what can you do? Narrow complex tachycardias. Narrow QRS complex, which is less than 120 milliseconds. Rapid ventricular activation via normal ventricular conduction system. Tachycardia originates within or above AV node. Supraventricular arrhythmia. So what are some examples of narrow complex tachycardias? Well, we have AFib, atrial fibrillation. We have multifocal atrial tachycardia, atrial flutter, paroxysmal supraventricular tachycardia. Those 4. So let's talk about AFib, atrial fibrillation. Description and EKG findings. I'm a little bit surprised they don't have that. I would assume that they have it somewhere, right? Let me just check through just to see I'm not missing anything. Nope, I am probably not. Okay. I'm a little bit surprised. So AFib, atrial fibrillation. Irregular rate and rhythm with no discrete P waves. Arrhythmogenic activity usually originates from the automatic foci near pulmonary vein, ostia, and left atrium. Common risk factors include hypertension, CAD, advanced age, atrial dilation, may predispose to thromboembolic events due to left atrial blood stasis, particularly stroke. Left atrial appendage is the most common site of thrombus formation in atrial fibrillation. Management of atrial fibrillation involves rate and rhythm control using beta blockers, calcium channel blockers, and digoxin, so A, B, C, D, and cardioversion. Okay. So it says here for the EKG findings, it shows irregular baseline, absent P waves. And it's saying the R to R intervals are not consistent. Multifocal atrial tachycardia. Irregular rate and rhythm with at least 3 distinct P wave morphologies due to multiple ectopic foci in atria, associated with underlying conditions such as COPD, pneumonia, and heart failure. Okay. Atrial flutter. Rapid succession of identical consecutive atrial depolarization waves leading to a sawtooth appearance of P waves. Arrhythmogenic activity usually originates from the re-entry circuit around tricuspid annulus. Treat like atrial fibrillation plus or minus catheter ablation of region between tricuspid annulus and the inferior vena cava. So it has a sawtooth appearance. Basically, it's like a normal QRS spike, but these little saw teeth in between them. Maybe this book shows about 4 between them, or 3 to 4 basically, or about 4. But it could be different, right? Because it's just kind of a pictorial depiction. There's a lot of little sawtooth between these QRS spikes, but the actual QRS spikes themselves are basically equal to one another. Paroxysmal supraventricular tachycardia. So paroxysmal supraventricular tachycardia, most often due to a re-entrant tract between the atrium and the ventricle, most commonly in AV node, commonly presents with sudden onset palpitations, lightheadedness, and diaphoresis. Terminate by slowing the AV nodal conduction, vagal maneuvers, or adenosine if that doesn't work. Definitively treat with catheter ablation. Now into Wolff-Parkinson-White syndrome, which again I don't see in the book here, unfortunately. Wolff-Parkinson-White. Let me just see if I want to just do Control F, but I don't know where it's going to lead me. So let's say I'm on 320. Yeah, let's say I'm on 320 hypothetically. Well, let's say that I'm on 318. I'm going to do Wolff. Oh, that's great. It is just like not mentioned. That's a little surprising. Anyway, Wolff-Parkinson-White syndrome. Most common type of ventricular pre-excitation syndrome. Abnormal fast accessory conduction pathway from atria to ventricle, bundle of Kent, bypasses the rate-slowing AV node, leading to ventricles partially depolarized earlier. This leads to characteristic delta waves with widened QRS complex and shortened PR interval. It may result in re-entry circuit, which leads to supraventricular tachycardia. How do you treat it? Procainamide, ibutylide, avoid AV node blocking drugs, for example, adenosine, calcium channel blockers, or beta blockers. And you can see this, for sinus rhythm, you see the delta wave, for orthodromic AV reentrant tachycardia, you can see the retrograde P wave, and for the antidromic AV reentrant tachycardia, you can see the delta wave again with the wide QRS. So there's kind of this variation in presentation, depending on how the sort of weird conduction pathway goes. Now we're on the wide complex tachycardias, talking about ventricular tachycardia, etc. I would assume they would have had something like this in this book. I guess they really don't care about the kinds of EKG findings in this book. I'm not sure why. So I'll continue then. Wide complex tachycardias. Wide QRS complex greater than 120 milliseconds. Slow ventricular activation outside of normal ventricular conduction system. Tachycardia originates below the AV node, ventricular arrhythmia. To arrhythmia and description. So what are the wide complex tachycardias? We have ventricular tachycardia, torsades, and ventricular fibrillation. So ventricular tachycardia, typically regular rhythm, rate is greater than 100, most commonly due to structural heart disease, that is to say cardiomyopathy, scarring after myocardial infarction. Higher risk of sudden cardiac death. And the EKG looks really crazy. I would look this up if I were you. For ventricular tachycardia, these huge waves that exist for that. Because again, there's this sort of thing going on with the ventricles themselves. There's a sort of independent depolarization, as far as I'm aware, in the ventricles themselves. It's called a ventricular tachycardia. Torsades de pointe. So again, I don't know, when you say torsades, people say torsades, but it's called torsades de pointe, pointe, I would assume it's pointe. Polymorphic ventricular tachycardia, shifting sinusoidal waveforms, may progress to ventricular fibrillation, long QT interval, that is to say, sinus bradycardia, congenital long QT syndromes, predisposes to torsades, caused by drugs that decrease potassium and decrease magnesium or decrease calcium. Torsades, torsade de points, twisting of the points. Treatment, defibrillation for unstable patients, magnesium sulfate for stable patients. Drug-induced long QT, A, B, C, D, E, F plus NO. So antiarrhythmics, 1A and 3, arsenic. Antibiotics, by the way, arsenic is not one of those two categories of antiarrhythmic, but it does cause it does induce it, nevertheless. B, antibiotics, macrolides and fluoroquinolones. C, antipsychotics with the spelling psychotics with a C as opposed to a PS, which is how you actually spell it. But whatever, they love doing that in this book. Antipsychotics, haloperidol, also chloroquine as well. Antidepressants, TCAs, as well as diuretics like thiazides. E, antiemetics, ondansetron. F, antifungals like fluconazole. And then also things like Navir, protease inhibitors, and opioids like methadone. And for torsades, it has that ribbon appearance where it looks like it gets like wider, and then it gets, in terms of the actual vertical axis, it looks like it's getting taller and then shorter and then taller and then shorter. It almost looks like when you look at a DNA strand, for example, where you look at I guess you could look at a streamer as well, and it's twisted, so it looks like it's wider in some areas and thinner in others. That's kind of what torsades looks like on the EKG. Ventricular fibrillation, VFib. Disorganized rhythm with no identifiable waves. How do you treat it? It's fatal without immediate CPR and defibrillation. So it just looks like a bunch of gunk. It's just random back and forth. There's no discernible rhythm to it. And now we would go on to hereditary channelopathies. Again, I don't know if they have a section on this. I feel like they just kind of revamped this stuff a lot in this section. So there's a lot of stuff about vasculitis. So it's talking about hereditary channelopathies. Inherited mutations of cardiac ion channels, which lead to abnormal myocardial action potential, which leads to an increased risk of ventricular tachyarrhythmias and sudden cardiac death, SCD. So there's two kinds that they're talking about here, Brugada syndrome and congenital long QT syndrome. But for Brugada syndrome, autosomal dominant, most commonly due to loss of function mutations of sodium channels, leading to an increased prevalence in Asian males, EKG pattern of pseudo-right bundle branch block and ST segment elevations in leads V1 and V2. It prevents SCD with ICD. Okay. So it's saying prevent sudden cardiac death with ICD. Congenital long QT syndrome. Most commonly due to loss of function mutations of potassium channels, which affects the repolarization. This includes Romano-Ward syndrome, autosomal dominant pure cardiac phenotype, no deafness, Jervell and Long-Nielsen syndromes. So Jervell, like Jervell, and Lang-Nielsen, so Lang, Lange, Nielsen, Nielsen. So Jervell and Lang-Nielsen syndrome, autosomal recessive, sensorineural deafness. 6, sinus syndrome, which is its own category of thing now. That's not a channelopathy, that's its own thing. 6, sinus syndrome, age-related degeneration of the SA node. EKG can show bradycardia, sinus pauses like delayed P waves, sinus arrest like drop P waves, and junctional escape beats. And now we're going to go into conduction blocks for a bit, but I'm going to go take a pause and a short break, or a break. Okay. And we're on 312 right now. So we went through 10 pages over the course of about half an hour, or an hour and a half, I should say. And we want to get to 328. So we might be here for another, I don't know. At least another hour and a half, and if not 2 hours or more than that. 2.5 at most, I suppose, maybe. Anyway. So I'm going to go back into conduction blocks. Conduction blocks, we have arrhythmia, description, EKG findings. What are some examples of conduction blocks? First degree AV block. It is a prolonged PR interval greater than 200 milliseconds. How do you treat it? None required. It's benign and asymptomatic. What about second degree AV block, which is also called a Mobitz type 1 or a Vankabach? Well, that will have progressive lengthening of the PR interval until a beat is dropped. P wave is not followed by a QRS complex. Variable RR interval with a pattern regularly irregular. How do you treat it? None required. Again, usually asymptomatic. What about a second degree AV block, Mobitz type 2? Drop beats that are not preceded by a change in PR interval may progress to third degree block, as it usually indicates a structural abnormality such as ischemia or fibrosis. How do you treat it? Usually a pacemaker. So even though I would say that when you look at a second degree Mobitz type 1, it looks more strange because like the PR interval is getting basically larger and larger until it just basically there's an absent QRS basically. It gets the PR interval gets so wide that eventually just the QRS complex is just gone. Like that seems like a weirder thing. Like, and then it eventually reoccurs in this sort of pattern essentially. So you would think that just a missing QRS every once in a while, as opposed to just this sort of weird PR interval expansion thing. You think that one, the one which is absent occasionally, would be the non-path, would be the less weird one, but it actually is the one more likely to be a pathology and indication of some sort of abnormality. So what about third degree block, which is called a complete block or a complete AV block, is third degree. P waves and QRS complexes rhythmically disassociate. Atria and ventricles beat independently of each other. Atrial rate is greater than the ventricular rate. It may be caused by Lyme disease. Treatment would be a pacemaker. So at that point, you'll see, and this is the best way to look at this, would be to look at the QRS complex and look at the gap between each QRS complex. It should be consistent. And then look at the gaps between the P waves and see how big the gaps are between those two. And you will see that the gaps are consistent for both, but the distance between them is different, which implies that they're just operating based off of different rates, essentially. They're different rates because they have different origins of their depolarizations. What about a bundle branch block? Interruption of the conduction of normal left or right bundle branches. Affected ventricle depolarizes via slower myocyte to myocyte conduction from the unaffected ventricle, which depolarizes via the faster His-Purkinje system, commonly due to degenerative changes, for example, cardiomyopathy, infiltrative disease. What about premature beats? I swear this entire section about that's all focused on EKG findings and stuff like that is completely not present in this older PDF. So I guess there's definitely some utility in buying the newer textbook editions. They talk about the pharmacology and showing the EKG stuff with that, but not the diseases. So they have interesting EKG findings. What's up with that? So premature beats. Arrhythmia, description, EKG findings. So premature atrial contraction, extra beats arising from the ectopic foci and atria instead of the SA node, often secondary to increased adrenergic drive, that is to say, for example, caffeine consumption. It's benign, but may increase risk for atrial fibrillation and flutter. Narrow QRS complex with preceding P wave on EKG. What's the other one? Would be premature ventricular contraction. Ectopic beats arising from ventricle instead of the SA node, shortened diastolic filling time, leading to a decrease in the stroke volume compared to a normal beat. Prognosis is largely influenced by the underlying heart disease, wide QRS complex with no preceding P wave on EKG. So again, if you look at that, I was talking before about the ventricular tachycardia, how these very long, these very tall complexes, these very tall waves, I should say. You will also find something similar, but in isolated form, in a premature ventricular contraction, where it's this very tall, very, very tall, what looks to be a QRS complex, or I guess you could say it's just a tall wave, if you will, compared to all the other QRS complexes that are present, because that's something that the ventricle would do, but it's isolated in this case. Now we're talking about myocardial infarction complications. Great, okay. So I thought we just talked about that like 5 minutes ago, or maybe half an hour ago, talking about that. I feel like they want to go into more detail, apparently, about it. And we'll go into cardiomyopathies actually later, apparently, as well. So here you go. Here's the myocardial infarction complications. So complication, time frame, findings, notes. So first complication, cardiac arrhythmia. It typically happens in the first few days to several months. Findings include, it can be supraventricular arrhythmia, ventricular arrhythmia, or a conduction block. Notes, due to myocardial death and scarring, it's an important cause of death before reaching the hospital and within the first 48 hours post-MI. What about a peri-infarction pericarditis? Well, that would be within 1 to 3 days. You have pleuritic chest pain, pericardial friction rub, EKG changes, and or small pericardial effusion. It is usually self-limited, though. What about papillary muscle rupture? That sounds pretty bad. 2 to 7 days. Can result in acute mitral regurgitation leading to cardiogenic shock and severe pulmonary edema. Now, this is predominantly posteromedial compared to the anterolateral papillary muscle ruptures. Mostly posteromedial, typically, as the posteromedial has a single artery blood supply, posterior descending artery, whereas the anterolateral has a dual blood supply, the LID and the left circumflex. And my thing has an image as well. Yours does too. It's the same image actually, showing the picture A, as you can see with the papillary muscle, the left ventricle, mitral valve, that kind of thing, for that papillary muscle rupture. Interventricular septal rupture, 3 to 5 days. Symptoms can range from mild to severe with cardiogenic shock and pulmonary edema. Macrophage-mediated degradation leading to a VSD, which leads to an increase in oxygen saturation and an increase in pressure in the right ventricle. And that gives you a hint of why it's 3 to 5 days. These ruptures are caused by macrophages because of degradation from macrophages. And these macrophages are popping up when? The back half of the first week. So between 3 to 5 days all the way into the second week, you'll have macrophages, and those things are causing degradation. And so that's where you're going to have all these ruptures. May it be papillary muscle rupture, may it be interventricular septal rupture. What about ventricular pseudoaneurysm? That's within 3 to 14 days. May be asymptomatic. Symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus. Rupture leads to cardiac tamponade. Free wall rupture contained by adherent pericardium or scar tissue. It does not contain endocardium or myocardium, most likely to rupture than true aneurysm. So pseudoaneurysm is a little bit more likely to happen than aneurysm is. The aneurysm is less likely. Ventricular free wall rupture happens within 5 to 14 days. This free wall rupture, which is shown in picture B in my book, I think is it picture B in your book? Yes. I think so. Yeah. Well, no. Not exactly. No. Free wall rupture is actually picture C in your book. Yes, there we go. So, free wall rupture leading to cardiac tamponade or internal hemorrhage is often fatal. Makes sense. Left ventricle hypertrophy and previous MI protect against free wall rupture. Oh, interesting. I didn't think about that. Okay. Well, apparently, even those things are basically pathological. Obviously, having a heart attack is pathological, right? Left ventricular hypertrophy, that's usually an indication source of pathology in the body. if you actually have those things, it actually will help protect you against the free wall rupture because, again, the wall is thicker, True ventricular aneurysm. Again, this is not the pseudoaneurysm, the true ventricular aneurysm. That happens within 2 weeks to several months. So this is after the MI actually happened and after the sort of consequences thereof, right? This is after the first 2 weeks. Symptoms similar to pseudoaneurysm, though. An outward bulge of contraction dyskinesia associated with fibrosis. Okay, because remember, the scar tissue has been forming at this point after the 2 weeks. You have a big white grayish scar. What about post-cardiac injury syndrome? Post-cardiac injury. Weeks to several months. Pericarditis due to autoimmune reaction. It's also called Dressler syndrome, as we were talking about before. Cardiac antigens released from after the injury, which leads to deposition of immune complexes in pericardium, which leads to inflammation. So basically, if I'm not mistaken, it's kind of like it says autoimmune right there. It is autoimmune. What's happening is this: the body is experiencing new antigens that it hasn't typically seeing on a regular basis. And as a consequence, there might be this sort of reaction between the antibodies that your body is producing already that are just kind of hanging around, and these new presenting antigens that normally wouldn't see, and it might have some sort of autoimmune consequence to that. Okay, and what about acute coronary syndrome, ACS treatments, acute coronary syndrome treatments? Unstable angina/NSTEMI, anticoagulation, heparin, antiplatelet therapy like aspirin, plus ADP receptor inhibitors like clopidogrel, beta blockers, ACE inhibitors, statins, symptoms control with nitroglycerin plus or minus morphine. What about STEMI? In addition to the things we mentioned above, reperfusion therapy most important, percutaneous coronary intervention preferred over fibrinolysis. If right ventricle affected, for example, like in an RCA occlusion, support venous return / preload to maintain cardiac output, that is to say, IV fluids, avoiding nitroglycerin. So avoid nitroglycerin potentially in that particular circumstance for a STEMI, particularly if it's a right ventricle issue. Now we can finally go on to cardiomyopathies, or as they say, well, I'm talking about dilated cardiomyopathy, so let's talk about that. So that's the ACS syndrome treatment stuff, okay. Cardiomyopathies. Dilated cardiomyopathy. Most common cardiomyopathy in 90% of cases, right? Often idiopathic or familial due to mutation of the TTN gene encoding the sarcomeric protein titin. Other etiologies include drugs, alcohol, cocaine, doxorubicin, infection like Coxsackie B virus or Chagas disease, ischemia like CAD, which is the coronary artery syndrome we were talking about before, systemic conditions like hemochromatosis, sarcoidosis, thyrotoxicosis, wet beriberi, peripartum cardiomyopathy. Findings include heart failure, S3 sound, systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance on heart chest x-ray. How do you treat it? Sodium restriction, ACE inhibitors / ARBs, which is that's basically angiotensin receptor blocker. Angiotensin receptor blockers. Beta blockers, sacubitril, diuretics, mineralocorticoid receptor blockers like spironolactone, ICD, heart transplant. And I want to confirm something as well with that before we go too much into it. Implantable cardioverter defibrillator. So ICD refers to an implantable cardioverter defibrillator. So I just need to keep that in mind as well. When they say ICD, that's what they mean. Systolic dysfunction ensues. We're talking about dilated cardiomyopathy, by the way. Systolic dysfunction ensues, displays eccentric hypertrophy, which you can see in the picture. A sarcomere is added in series. Compared to athlete's heart, where the left ventricle and right ventricle enlargement facilitates an increase in the stroke volume and an increase in cardiac output. Stress cardiomyopathy, also known as Takotsubo cardiomyopathy, broken heart syndrome, ventricular apical ballooning, likely due to increase in sympathetic stimulation, for example, in stressful situations. Hypertrophic cardiomyopathy. 60 to 70% of all cases are familial, autosomal dominant, most commonly due to mutations in genes encoding sarcomeric proteins such as myosin-binding protein C and beta-myosin heavy chain, causes syncope during exercise and may lead to sudden death, that is to say, in young athletes due to ventricular arrhythmias. Findings: S4, systolic murmur, may see mitral regurgitation due to impaired mitral valve closure. Treatment would be use beta blockers or non-hydropyridine calcium channel blockers like verapamil, that kind of thing. Diltiazem would be the other one that we think of. And in some cases, cessation of high intensity athletics. In ICD, if high risk, avoid drugs that decrease preload, for example, diuretics or vasodilators. Diastolic dysfunction ensues. Displays ventricular concentric hypertrophy, sarcomeres added in parallel, which is shown in picture B right there, as you can see. Often septal predominance, myofibrillar disarray, and fibrosis. Classified as a hypertrophic obstructive cardiomyopathy when the left ventricular outflow tract is obstructed. Asymmetric septal hypertrophy and systolic anterior motion of mitral valve leading to outflow obstruction, leading to shortness of breath and possible syncope. What about restrictive/infiltrative cardiomyopathy? Well, post-radiation fibrosis, Loeffler endocarditis, endocardiofibroelastosis, thick fibroelastic tissue, and endocardium of young children, amyloidosis, sarcoidosis, hemochromatosis, please help. And they say puppy lesion, your thing. It doesn't really matter in my opinion, I could care less. Diastolic dysfunction ensues. Can have low voltage EKG despite thick myocardium, especially in amyloidosis. Loeffler endocarditis associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates in myocardium. And now we'd be going on to heart failure. Heart failure. Clinical syndrome of cardiac pump dysfunction, leading to congestion and low perfusion. Symptoms include dyspnea, orthopnea, fatigue. Signs include S3 heart sound, rales, jugular venous dissension, JVD, pitting edema. And you can see that in the picture as well. Systolic dysfunction, heart failure with reduced ejection fraction, HFrEF, leading to you have increased end diastolic volume, decreased contractility, often secondary to ischemia/MI or dilated cardiomyopathy. Diastolic dysfunction, heart failure with preserved ejection fraction, HFpEF, decreased compliance which is to say increased end diastolic pressure, often secondary to myocardial hypertrophy. So a decreased compliance leading to elevated end diastolic pressure. Okay. Related to it. Right heart failure often results from left heart failure. True. Cor pulmonale refers to an isolated right heart failure due to pulmonary cause. So basically, what happens is that let's say you have a left heart failure. Well, that's going to cause a buildup of blood into the pulmonary system, which will then lead to a buildup of blood in the right heart system. And so there's sort of this backtracking that you experience. And that's why that's why the number one cause of right heart failure is left heart failure. However, cor pulmonale, where you have a hypertension, pulmonary hypertension, or let's say some sort of issue with the pulmonary system, that could cause a right heart failure without necessarily having a left heart failure problem going on at the same time. But it's still a concept of backtracking, essentially. ACE inhibitors, A or Bs, angiotensin receptor neprilysin inhibitors, beta blockers, except in acute decompensated heart failure, and aldosterone receptor antagonists decrease mortality in heart failure with reduced ejection fraction. Loop and thiazide diuretics are used mainly for symptomatic relief. Hydralazine with nitrate therapy and SGLT2 inhibitors improve both symptoms and mortality in select patients. Left heart failure, orthopnea, shortness of breath when supine, leading to an increase in venous return for redistribution of blood, immediate gravity effect. This exacerbates pulmonary vascular congestion. Paroxysmal nocturnal dyspnea, breathless awakening from sleep, but with an increased venous return from redistribution of blood, reabsorption of peripheral edema, and so forth. Pulmonary edema. There's an increase in pulmonary venous pressure, which leads to pulmonary venous distension and transudation of fluid. Presence of hemosiderin-laden macrophages, heart failure cells, in lungs. Right heart failure. There's a little chart right there as well for you to look at to see, left ventricular contractility, etc., etc. Right heart failure, congestive hepatomegaly, increase in central venous pressure, leading to an increase in resistance to portal flow, rarely leads to cardiac cirrhosis, associated with nutmeg liver, modeled appearance on gross exam. And why is that? Again, it's a backtracking thing. Because if you have an issue with the right heart failure, blood's going to start pooling up to everything before that, coming into it, feeding into it. And so you will have things like JVD, peripheral edema, and yes, hepatomegaly as well. But jugular venous dissension, we have an increased venous pressure. Peripheral edema, you have an increased venous pressure leading to a fluid transudation. And so you can see the diagram right there as well. I have my own diagram going on as well, a little bit more complicated, along with two smaller diagrams as well. So let's talk about high output heart failure. If they have it. They have shock. So I'll just read about high output heart failure first. So high output heart failure, uncommon form of heart failure characterized by an increase in cardiac output. Oh, that's weird. High output state is due to the decrease in systemic vascular resistance from either the vasodilation or the arterial venous shunting. Causes include severe obesity, advanced cirrhosis, severe anemia, hyperthyroidism, wet beriberi, Paget disease of bone. Presents with symptoms and signs of pulmonary and/or systemic venous congestion. What about shock? Shock, inadequate organ perfusion and delivery of nutrients necessary for normal tissue and cellular function, initially may be reversible but life-threatening if not treated promptly. Okay. So we have different kinds of shock. We have hypovolemic, cardiogenic, obstructive, and distributive. So we'll talk about hypovolemic. So we have caused by, mechanism, skin, ZVP, PCWP, cardiac output, systemic venous resistance, systemic vascular resistance, and an SVO2. So I might just refer to that as whatever, but PCWP referring to the wedge pressure and stuff like that. So hypovolemic shock is caused by hemorrhagic dehydration and burns. Its mechanism is going to be volume depletion. The skin is going to be cold and clammy. You have decreased CVP, decreased wedge pressure, decreased cardiac output, increased vascular resistance, and decreased SVO2. What about cardiogenic shock? Cardiogenic shock will be caused by an MI, heart failure, valvular dysfunction, arrhythmia. Mechanism would be left heart dysfunction. You have cold and clammy skin with increased CVP, increased wedge pressure, decreased cardiac output, which is the driving thing. So the wedge pressure is the biggest issue for hypovolemic shock. The big issue, primary problem, is the cardiac output in the case of cardiogenic shock. So cardiogenic shock, decreased cardiac output, increased SVR, decreased SVO2. What about obstructive shock? That can be caused by either pulmonary embolism and tension pneumothorax, or it can be caused by, and it's going to have a different presentation, or cardiac tamponade. So these would have an impeded cardiopulmonary flow of blood, and they will have cold and clammy skin. If you have a PE or tension pneumothorax, it will cause increased CVP, decreased wedge pressure, decreased cardiac output, which is the driving thing. That's the big issue. increased SVR and a decreased SVO2. For cardiac tamponade, you will have an increased CVP, an actual increased wedge pressure, which is different, a decreased cardiac output, which is the driving problem again, an increased SVR, and a decreased SVO2. So the big difference is cardiac tamponade will have an increased wedge pressure, actually. What about distributive shock? Well, distributive shock is a little bit different. You have two different groups. So sepsis, which is early, or anaphylaxis, and the other camp is CNS injury. So let's say you have sepsis or anaphylaxis. It will have systemic vasodilation. You have warm or dry skin, which is different, right? You have decreased CVP, decreased wedge pressure, increased cardiac output, which is interesting, decreased SVR, which is the driving problem, and you have a increased SVO2. What about CNS injury? CNS injury will also have systemic vasodilation. You have warm, dry skin, like before. You have decreased CVP, decreased wedge pressure. You actually have a decreased cardiac output. Okay, so that's different from the sepsis early on and the anaphylaxis. So you'll have a decreased cardiac output in this case for CNS injury. You have a decreased SVR, which is the primary disturbance, again, driving the shock. And you have either a normal or an elevated SVO2. Okay. We were talking about cardiac tamponade, but I don't see that section here right now, so I don't know if it's covered later on. Right here. Cardiac tamponade. Compression of the heart by fluid, that is to say blood or effusions, leading to a decrease in cardiac output. Equilibrium of diastolic pressure in all four chambers. Findings. Beck triad. Hypotension, distended neck veins, distant heart sounds. Increase in heart rate. Pulses paradoxus. EKG may show low voltage QRS and or electrical alternans due to swinging. Movement of heart and lung effusion. Echocardiogram shows pericardial effusion, which is shown with the arrows at A, but doesn't have that here anyways. Okay. How do you treat it? So echocardiogram shows pericardial effusion, systolic right atrial collapse, diastolic right ventricular collapse, and inferior vena cava plephora. How do you treat cardiac tamponade? Pericardiocentesis or surgical drainage. You have to remove the fluid, basically. Pulsus paradoxus. Not sure if that's covered here. Pulsus paradoxus, a decrease in amplitude of systolic blood pressure by more than 10 mmHg during inspiration. Increase in venous return during inspiration, leading to an increase in right ventricular filling. This leads to an interventricular septum, bows toward left ventricle due to the decrease in pericardial compliance. This leads to a decrease in left ventricular ejection volume, which leads to a decrease in systolic blood pressure. This is seen in constrictive pericarditis, obstructive pulmonary disease like CRU, OSA, asthma, COPD. Also, you might have it in the case of cardiac tamponade. So, like, they call that PCO. So, PCO. So, you have CRU, OSA, asthma, and then also tamponade, and also pericarditis. Those are things that can cause pulsus paradoxus, where you have, again, that decrease in amplitude of systolic blood pressure by more than 10 during inspiration. Let's see if we can find syncope in here. I want to see how... Oh, okay. Pharmacology begins on 321. We're on 318 right now. And we wrap up on 328. I believe, right? Yeah, we do. So let me find syncope if I can. What's this? Vasculitis? Okay. Do we even get into vasculitis? I almost certainly would have to, right? Oh, I have Kussmaul sign here. Myocarditis. I guess that was a bigger deal back in the day. I'm not going to cover that if it's not covered in my book here. If they decide to ditch it, then I'll ditch it too, for my reading. You're free to read it if you want to. Whatever. Look right here. Syncope. Syncope is a transient loss of consciousness caused by a period of decreased cerebral blood flow. Types include reflex, orthostatic, and cardiac. So reflex syncope, most common, vasovagal, also called vasovagal syncope, by the way, vasovagal. Prodromal symptoms include warmth, pallor, nausea. Episodes are short with rapid recovery, situational with coughing and sneezing, swallowing, defecation, micturition. Carotid sinus hypersensitivity, wearing tight collar. Orthostatic, you have hypovolemia, drugs, for example, antihypertensives. Autonomic dysfunction. Orthostatic hypotension is defined as a drop in systolic blood pressure greater than 20 mmHg and or diastolic blood pressure of greater than 10 mmHg within 3 minutes of standing. So this is like somebody who gets up out of their chair, they've been sitting there for maybe an hour, they get out of their chair and then they collapse. Their body wasn't able to quickly compensate for the change in blood pressure because you're standing up straight now all of a sudden. Cardiac. So the cardiac syncope, arrhythmias, structural, that is to say like aortic stenosis or hypertrophic cardiomyopathy. What about infective endocarditis? What about that stuff? So infective endocarditis, infection of the endocardial surface of the heart, typically involving greater than one or more heart valves, caused by bacteria far more than fungi, although I guess fungi could also be a problem too. It forms acute or subacute. Acute, classically Staph aureus, high virulence, large destructive vegetations on previously normal valves, rapid onset. Or subacute, classically viridans or streptococci, which is low virulence, smaller vegetations on congenitally abnormal or diseased valves, so they're already a problem beforehand. Sequelae of dental procedures, gradual onset. Presents with fever, most common, new murmur, vascular and immunologic phenomena. Vascular phenomenon, septic embolism, petechiae, splinter hemorrhages, linear hemorrhagic lesions on nail bed, Janeway lesions, painless flat erythematous lesions on palms or soles. Immunologic phenomenon would be immune complex depositions, glomerular nephritis, Osler nodes, which are painful, O for ouchie, Osler O, ouchie O, whatever. Raised, violaceous lesions on fingers and toe pads, Ross spots, retinal hemorrhagic lesions with pale centers. Remember what Osler nodes and Ross spots are and what they're related to, of course. We're continuing with infective endocarditis here. Mitral valve, most common, followed by aortic valve. Tricuspid valve involvement is associated with injection drug use. Don't try drugs. So tricuspid with drug use. Common associations, prosthetic valves, think staph epidermidis for prosthetic valves. For GI and GU procedures, think enterococcus. For colon cancer, think strep galolyticus. That's a very weird one, but yes, it will also cause colon cancer. For galolyticus, also called bovis, by the way. Gram negatives, think high-check organisms, HACEK. Those are going to be Haemophilus, Aggregatibacter, which used to be called Actinobacillus, Cardiobacterium, Eikenella, and Kingella. So the gram negatives can cause this issue as well. Culture negative, think Coxiella and Bartonella. For injection drug use, think Staph aureus, Pseudomonas, and Candida. For endothelial injury, think formation of vegetations consisting of platelets. So our endothelial injury leads to formation of vegetations consisting of platelets, fibrin, and microbes on heart valves, leading to valve regurgitation, septic embolism, systemic circulation in left-sided endocarditis, pulmonary and right-sided. Diagnosis requires multiple blood cultures and echocardiography. Now about non-bacterial thrombotic endocarditis, also called the marantic endocarditis. That's MARANTIC, marantic endocarditis. Rare, non-infective, vegetations typically arise on mitral or aortic valve and consist of sterile, platelet-rich thrombi that dislodge easily, usually asymptomatic until embolism occurs. Associated with the hypercoagulable state seen in advanced malignancy, especially in pancreatic adenocarcinoma or SLE, lupus basically. called Liebman-Sachs endocarditis in this setting for SLE. Rheumatic fever. Okay, finally we're rheumatic fever now. Now we're overlapping with what the PDF says. Rheumatic fever, a non-suppurative consequence of pharyngeal infection with group A beta hemolytic streptococci. A late sequela include rheumatic heart disease. Late sequelae include rheumatic heart disease, which affects the heart valves. Mitral more than aortic, much greater than tricuspid, which is high pressure valve affected most. Early valvular regurgitation, late valvular stenosis. Associated with the Aschoff bodies, it's ASCHOFF bodies, Aschoff bodies, granuloma with giant cells, and Anichkow, which is ANITSCHKOW cells, Anichkow cells, in large macrophages of ovoid, wavy, rod-like nucleus, an increase in anti-streptolysin O, ASO, and an increase in anti-DNAase, B titers. And bear in mind, DNAase is a thing that I think Strep pyogenes makes. That would make sense. That checks out. Because that's a beta hemolytic streptococcus. Immune-mediated type 2 hypersensitivity, not a direct effect of bacteria. Antibodies to M protein cross-react with self-antigens, often myosin, molecular mimicry. Treatment with prophylaxis would be with penicillin, so use penicillin. And remember, rheumatic fever, which again is caused by Strep pyogenes, group A strep, has the Jones criteria, major criteria for rheumatic fever. Joint, migratory polyarthritis. There's a little heart sign, make the O, but it's actually referring to pancreatitis. Nodules in the skin, which is subcutaneous. Erythema marginatum, which is going to be evanescent rash with ring margin. And then Sydenham chorea, which is involuntary irregular movements of limbs and face. So Jones, joint, the heart for pancreatitis, nodule in skin, erythema marginatum, and Sydenham chorea, I should say. Now I have syphilitic heart disease, which I would assume is either not present or, here we go. Syphilitic heart disease. Tertiary syphilis disrupts the vasa vasorum of the aorta with the consequent atrophy of vessel wall and dilation of aorta and valve ring. May see calcification of aortic root, ascending aortic arch, and thoracic aorta, leads to the tree bark appearance of aorta. Can result in aneurysm of ascending aorta or aortic arch, aortic insufficiency. Acute pericarditis. Inflammation of the pericardium, red arrows shown in A. Commonly presents with sharp pain aggravated by inspiration and relieved by sitting up and leaning forward. Often complicated by pericardial effusion between the yellow arrows shown in A as well. Presents with friction rub. EKG changes include widespread diffuse ST segment elevation and or PR depression. Usually idiopathic, but may be due to viral infections, for example, Coxsackie virus B, malignancy, metastasis, cardiac surgery, thoracic radiotherapy early, and MI, for example, post-cardiac injury syndrome, so Dressler syndrome. Autoimmune diseases like lupus, drug-induced lupus, rheumatoid arthritis, or renal failure like uremia. How do you treat acute pericarditis? You treat with NSAIDs, colchicine, glucocorticoids, or dialysis with uremia. What about constrictive pericarditis? Do we have that? I don't think so, no. Constrictive pericarditis, let's just go through it, okay? Chronic inflammation of the pericardium leading to pericardial fibrosis plus or minus calcification, which leads to limited space for expansion, which leads to decrease in ventricular filling, of course. Usually idiopathic, but may be due to viral infections, cardiac surgery, thoracic radiotherapy, late. TB is the most common cause in resource-limited countries. They probably mean developing countries, i.e. people historically would say that's called a third world country. Basically, think about the global, they have all sorts of terms for that. Low-income country. What do they say here? They say resource-limited countries. Okay. They say resource-limited countries. I would assume they mean like the global south, but I'm not quite sure. But they might mean something different, I guess. Decrease in end-diastolic volume, leading to a decrease in cardiac output, leading to decrease in venous return. Presents with dyspnea, peripheral edema, and jugular venous distension, Kussmaul sign, pulsus paradoxus, and pericardial knock. So let's talk about Kussmaul sign. We have basically a little bit less than a page and a half, and then we're going to be finished with the pathology section and transition over into the pharm section. So Kussmaul sign. Paradoxical increase in JVP on inspiration. Normally, inspiration leads to a negative intrathoracic pressure, leading to an increase in venous return, which leads to a decrease in JVP. Impaired right ventricular filling, though, will lead to right ventricular cannot accommodate, which causes an increased venous return during inspiration. This leads to blood backs up into the vena cava, leading to Kussmaul sign. May be seen with constrictive pericarditis, restrictive cardiomyopathy, or right heart failure. Yeah. Massive pulmonary embolism, right atrial, or ventricular tumors. Now we're talking about myocarditis. Is that in here? Oh, we have bacterial endocarditis up here. Okay. Okay, so that's the all that stuff with rheumatic fevers up here as well. So they mentioned from Jane, okay, for Osler nodes, all that kind of stuff. Okay, you can look at that if you want to. But I want to look at myocarditis right now. Oh, apparently myocarditis is again neglected. So let's talk about it. Myocarditis. Inflammation of myocardium. Major cause of SCD in adults. I would assume that means SCD in this context probably means something like they were using it before. I forgot what they were referring it to. It's not subcombined acute degeneration or something like that. It's not SCD heart. Sudden cardiac death. Okay, there we go. That's more relevant. So myocarditis, inflammation of myocardium, major cause of sudden cardiac death in adults less than 40 years of age. Presentation is highly variable, can include dyspnea, chest pain, fever, arrhythmias, persistent tachycardia out of proportion to fever is characteristic. Multiple causes including viral, for example, adenovirus, Coxsackie B virus, parvovirus B19, HIV, HHV6, COVID-19, lymphocytic infiltrate with focal necrosis, highly indicative of viral myocarditis. We also have parasitic, for example, Trypanosoma cruzi or Toxoplasma gondii. We have bacterial, like Borrelia burgdorferi, Mycoplasma pneumonia, and Corynebacteria diphtheria. Toxins like carbon monoxide and black widow venom. Okay. We have rheumatic fever, as well as drugs like doxorubicin and cocaine. We also have autoimmune situations like Kawasaki disease, sarcoidosis, lupus, and polymyositis and dermatomyositis. Complications include sudden death, arrhythmias, heart block, dilated cardiomyopathy, heart failure, mural thrombus with systemic emboli. Not so fun. Hereditary hemorrhagic telangiectasia. Telangiectasia. Okay. Hereditary hemorrhagic telangiectasia. Also called Osler-Weber-Rendu syndrome. That's fun. It's kind of silly. Osler-Weber-Rendu syndrome. Sounds like a little bit more whimsical, a little bit less harmful, you know. Rendu syndrome. Okay. Autosomal dominant disorder of blood vessels. Findings: blanching lesions, for example, tongue telangiectasias on skin and mucous membranes, recurrent epistaxis, arteriovenous malformations, for example, in the brain, lung, and liver, GI bleeding, hematuria, arteriovenous malformation, abnormal high flow connection between the artery and the vein with increased risk of high output cardiac failure, most common cause of intracranial hemorrhage in children. And now we're on cardiac tumors now. Cardiac tumors. Most common cardiac tumor is a metastasis, that is to say, a melanoma. So we have that within that myxomas. Most common primary cardiac tumor in adults, which is shown in the arrow for A. 90% occur in the atria, mostly left atrium. Myxomas are usually described as a ball valve obstruction in the left atrium associated with multiple syncopal episodes. IL-6 production by tumor leading to constitutional symptoms, for example, fever, weight loss, may auscultate early diastolic tumor plop sound, mimics the mitral stenosis. Histology would be gelatinous material, myxoma cells immersed in glycosaminoglycans. Adults make 6 mixed drinks. Okay, adults make 6 mixed drinks. What does that mean? It's an adult tumor, most common primary cardiac tumor in adults. It is associated with IL-6 production by the tumor is what's made, and you have, it's called a myxoma. But anyway, what about rhabdomyomas? Rhabdomyomas, they are the most frequent primary cardiac tumor in children, okay, associated with tuberous sclerosis, histology, hamartomas growths, more common in the ventricles. Okay, so rhabdomyoma is the most common in children, myxoma the most common in adults. Now we're going to be talking about DVT, which is kind of its own little category thing. Well, they really did just kind of drop the entire vasculitis stuff from this version of the textbook. I guess it's not as relevant as they thought it would be. Let me talk about DVT. Deep venous thrombosis. Blood clot within a deep vein leading to swelling and redness, warmth and pain. Predisposed by Virchow triad, SHE or she. S, stasis. Post-op, long drive or flight. H, hypercoagulability, that is to say, defect in coagulation cascade proteins such as factor V Leiden, oral contraceptive use, or pregnancy. And then E, endothelial damage, exposed collagen triggers clotting cascade. DVT of proximal deep veins of the lower extremity, for example, iliac, femoral, popliteal, leads to embolic resource. D-dimer may be used to clinically to rule out DVT if disease probability is low or moderate, high sensitivity, low specificity. Imaging test of choice is compression ultrasound with Doppler. Use unfractionated heparin or low molecular weight heparins, that is to say enoxaparin, for prophylaxis and acute management. Use direct anticoagulants, for example, rivaroxaban or apixaban, for treatment and long-term prevention. Okay, and I want to just show you this over here. If you want to read this, go ahead, pause the video, and see this is vasculitides. So large vessel vasculitis, medium vessel vasculitis, small vessel vasculitis. Right here, vasculitides continued, small vessel vasculitis continued. Hereditary hemorrhagic telangiectasia, which we were talking about before, Rendu syndrome. So that section is basically cut out as at some point after 2017. That would kind of imply that the people who are the authors of this textbook don't think it's as relevant as you might think it would be otherwise, and so they basically removed most of it. And so bear that in mind if you want to study that. It might not be as relevant as you might think. So now we're going to the pharmacology section, but before I get into that, I'm going to take a short break. Bear in mind, we're on page 321 right now in my textbook, and we will wrap up on 328. And the break might be, I don't know, it might not be super short, but it will be a break. Okay, we are back from our break, and we will try to proceed into the last section of this chapter, looking now at the pharmacology section of the cardiovascular chapter. Again, we are in 321 of my textbook, and we'll wrap up on 328. Now, there's going to be some graphs and stuff like that, some diagrams, and so it's not as crazy as you might think, unless you want to go actually look at the diagrams themselves, which I would recommend you reviewing that later on. I'm just saying it might not be as much reading as you would suspect. So, cardiovascular pharmacology section. Hypertension treatment. Primary essential hypertension. What do you treat it with? Thiazide diuretics, ACE inhibitors, angiotensin II receptor blockers, ARBs, calcium channel blockers. Hypertension with heart failure. What do you treat it with? ACE inhibitors / ARBs, beta blockers, compensated heart failure, aldosterone antagonist, mortality benefit, diuretics, improve symptoms and reduce hospitalization. It says here in part of the notes, beta blockers must be used cautiously in decompensated heart failure and are contraindicated in cardiogenic shock. What about hypertension with diabetes mellitus? You treat it with ACE inhibitors / ARBs, calcium channel blockers, thiazide diuretics, and beta blockers. It says here, ACE inhibitors / ARBs are protective against diabetic nephropathy. That's important to know. ACE inhibitors and ARBs are good for diabetic nephropathy, protective against it. Beta blockers can mask hypoglycemia symptoms. Oh, interesting. Okay, that's a good point. So if you have hypoglycemia, if you have a beta blocker, you might not be able to tell. And that's a concern to be aware about. Okay, good point. Hypertension with asthma. ARBs, hypertension with asthma, you treat with ARBs. And not with ACE inhibitors. Remember, ACE inhibitors would be an issue. And they'll talk about that soon. You treat with ARBs, calcium channel blockers, thiazide diuretics, and cardioselective beta blockers. In the notes it says here, avoid non-selective beta blockers to prevent beta-2 receptor-induced bronchoconstriction. Very true. Also, avoid ACE inhibitors to prevent confusion between drug or asthma-related cough. I would say it like this. ACE inhibitors mess with bradykinin. You will have increased levels of bradykinin because it's not being broken down when you have an ACE inhibitor to the same degree. So more bradykinin means you're going to have more coughing. And so even though you might say, oh, you don't want to confuse the coughing from the asthma versus coughing from the bradykinin excess because of ACE inhibitors, I would just say you don't really want to be coughing a lot. And so you already have an issue with asthma, you don't want to make that worse. Hypertension with pregnancy. How do you treat it? Hydralazine, methyl-dopa, labetalol, and nifedipine. And they have a little mnemonic for those. They say, hypertensive moms love nifedipine. Okay, that's so, okay. But hydralazine, methyl-dopa, labetalol, and nifedipine. Those are good ones. What about hypertension with gout? What do you do? ACE inhibitors, calcium channel blockers, ARBs, especially losartan. It says here, avoid loop and thiazide diuretics as these can cause gout flares. Interesting. And going along with that, we're going to hypertension of osteoporosis. It says here you treat it with thiazides preferred as monotherapy, combined with ACE inhibitors or ARBs if needed. And they say here, thiazides preferred due to calcium channel reabsorption. For calcium reabsorption, okay. What about hypertension with pheochromocytoma? What do you do in that circumstance? It says here, phentolamine, good point. Phenoxybenzamine, also a good point, which is an alpha blockade first, prior to resection and beta blockade. Very true. And phentolamine, think about phentolamine as a phantom. It's kind of ephemeral. It comes and goes pretty quickly. It's reversible. But phenoxybenzamine, think like a phoenix. It's kind of this eternal thing. It's not reversible. It's irreversible. So it says here in the notes, avoid beta blockade first to mitigate unopposed alpha-mediated hypertensive crisis. Okay, so they're... Okay. Now I'm going to go over the cardiovascular agents and molecular targets. And they have a different way of organizing some of this information, talking about each individual thing, calcium channel blockers. Oh, my book has that too. Okay, so I'll see if I have some of that too. They talk about nitrates first, so I'll talk about that first. There's a big diagram in my book talking about the different kinds of things and how they act. I like this diagram a lot. I might have to put this in my notes or something like that to review. Put in one of my presentations to review after the fact. But they have dihydropyridine calcium channel blockers, GQ for agonists, nitrates, PDE5 inhibitor, natriuretic peptide agonists, PDE3 inhibitor, GS agonists, GI agonists. Sounds very fun or useful. Okay, let's talk about nitrates. Nitrates: nitroglycerin, isosorbide, dinitrate, isosorbide mononitrate. Mechanism: vasodilate by increasing the nitric oxide in the vascular smooth muscle, leading to an increase in cyclic GMP and smooth muscle relaxation. This causes a lot of dilation of the veins, with some arterial dilation as well. This decreases preload. What is it used for? Angina, ACS, and pulmonary edema. Adverse effects: reflex tachycardia, you treat with beta blockers, methemoglobinemia, hypotension, flushing, headache, Monday disease and industrial nitrate exposure, development of tolerance for the vasodilating action during the work week, and loss of tolerance over the weekend, leading to tachycardia, dizziness, headache upon re-exposure. Contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDE5 inhibitor use. So that'd be like sildenafil or tadalafil or something like that. You don't want to use that with a nitrate at the same time. What about calcium channel blockers? Calcium channel blockers. Like amlodipine, clofidipine, nicardipine, nifedipine, nimodipine. These are dihydropyridines, act on vascular smooth muscle. We also have diltiazem and verapamil, which are non-dihydropyridines, which act on the heart. The mechanism: they block voltage-gated L-type calcium channels of the cardiac and smooth muscle, leading to a decrease in muscle contractility. Vascular smooth muscle, amlodipine, equals nifedipine, greater than diltiazem, greater than verapamil. So basically what they're saying is the dihydropyridines are very focused on the vascular smooth muscle. Well, the heart is predominantly focused on by verapamil and diltiazem. Amlodipine and the other kinds of dihydropyridines are less focused on the heart, basically. Clinical use: dihydropyridines except nimodipine, hypertension, angina, including vasospastic type, Raynaud phenomenon. Dihydropyridine mainly dilates arteries. Nimodipine, subarachnoid hemorrhage, prevents delayed ischemia. Nicardipine, clofidipine, hypertensive urgency or emergency. Non-dihydropyridines, hypertension, angina, rate control, and AFib or /A flutter, prevention of nodal arrhythmias. The adverse effects: gingival hyperplasia. That's a weird one, and it pops up a couple different times. Different kinds of drugs cause gingival hyperplasia. Dihydropyridines can cause peripheral edema, flushing, and dizziness. And non-dihydropyridines can cause cardiac depression, AV block, and hyperprolactinemia, like verapamil, constipation as well. Let's talk about hydralazine now. Hydralazine mechanism: increases cyclic GMP, leading to smooth muscle relaxation. Hydralazine vasodilates arterioles more than veins. Afterload reduction. Okay. Clinical use: severe hypertension, particularly the acute, heart failure with organic nitrate, safe to use during pregnancy, frequently co-administered with a beta blocker to prevent reflex tachycardia. So it's sort of similar to what happens when you have nitrate, for example. It's, we need to give a beta blocker just to prevent the reflex tachycardia from popping up. Adverse effects of hydralazine: compensatory tachycardia, contraindicated in angina/CAD, fluid retention, headache, angina, drug-induced lupus. What about hypertensive emergency? Hypertensive emergency, you treat with albuterol, clofidipine, phenoldiprem, nicardipine, and nitroprusside. Nitroprusside, short-acting vasodilator, arteries equal to veins, increases cyclic GMP via the direct release of nitric oxide, can cause cyanide toxicity. True, releases cyanide, yeah, and that's no fun. Phenoldiprem, which is the other one, phenoldiprem, dopamine D1 receptor agonist, coronary, peripheral, renal, and splanchnic vasodilation, decrease in BP, increase in natriuresis, also used post-operatively as an antihypertensive, can cause hypotension, tachycardia, flushing, headache, and nausea. Anti-anginal therapy. Goal is reduction of myocardial O2 consumption, MVO2, by a decrease in one or more of the determinants of MVO2, end diastolic volume, BP, heart rate, contractility. End diastolic volume. Nitrates, beta blockers, nitrates plus beta blockers. End diastolic volume leads to a decrease in nitrates. Beta blockers will have no effect or increase beta blockers. Nitrates plus beta blockers has no effect or a decrease in beta blockers. Oh, let me read this differently. Sorry, I'm reading this in a bad way. For nitrates, for example, nitrates have a decreased end diastolic volume, decreased blood pressure, an increase in contractility, which is a reflex response, an increase in heart rate, because that's a reflex tachycardia, a decreased ejection time, and a decreased MVO2. And I just want to say something quickly, clarify something. MVO2 refers to the myocardial oxygen consumption. So I've been talking about MVO2 a lot, and I've not clarified what that is because I didn't necessarily know what that stands for. Myocardial oxygen consumption. Anyway, beta blockers have no effect or an increase in end diastolic volume. They have a decrease in blood pressure, a decrease in contractility, a decrease in heart rate, an increase in ejection time, and a decrease, again, in myocardial oxygen consumption. What about nitrates plus beta blockers? What happens with that? Well, they have no effect or decreased end diastolic volume. They have a decreased blood pressure. They have little or no effect on the contractility. They have no effect or decreased heart rate. They have little to no effect on ejection time, but they have a significant decrease in the myocardial oxygen consumption. Okay, the MVO2. It says here, non-dihydropyridine calcium channel blockers like verapamil and diltiazem are similar to beta blockers in effect. Okay. Now we're talking about ranolazine. Ranolazine mechanism. Ranolazine inhibits the late phase of inward sodium current, thereby reducing the diastolic wall tension and oxygen consumption. It does not affect the heart rate or the blood pressure. Clinical use: refractory angina. Adverse effects: constipation, dizziness, headache, nausea, QT prolongation. Sacubitril. I don't like saying that one. It's hard for me to say. Sacubitril. Here we go. That's not bad. Okay, sacubitril. Does it even mention it? I don't see it in this PDF, but I will go down to Milrinone. But sacubitril mechanism: a neprilysin inhibitor prevents degradation of bradykinin, natriuretic peptides, angiotensin II, and substance P, leading to an increase in vasodilation and a decrease in ECF volume. What do you use it for? Clinical use for sacubitril? Used in combination with valsartan, which is an ARB, to treat the heart failure with reduced ejection fraction. Adverse effects of sacubitril: causes hypotension, hyperkalemia due to the ARB component of heart failure with reduced ejection fraction therapy, cough, dizziness, contraindicated and with ACE inhibitors due to the angioedema. Both drugs increase bradykinin. Okay, so a similar mechanism for why there's issues with the lungs with ACE inhibitors as well. There's a little diagram showing the neprilysin inhibitor, sacubitril, inhibiting angiotensin II becoming inactive products, and angiotensin and natriuretic peptides becoming inactive products as being inhibited by sacubitril, which is an neprilysin inhibitor. And likewise, we see the natriuretic peptides decreasing vascular tone and the angiotensin II increasing vascular tone, which is related to and aldosterone secretion as well, those two. While the valsartan, which is an angiotensin receptor blocker, an ARB, is actually decreasing angiotensin II from improving or increasing vascular tone and aldosterone secretion. So they're kind of like operating in different parts of the same overall mechanism, I guess in a sense, related to angiotensin II. Milrinone is not mentioned in my section quite yet, or if at all. It might not be mentioned at all. Nevertheless, I would read about it. It is a drug that might come up. Wait, is it mentioned at the end? No, it's not. Milrinone, it's a PDE3 inhibitor, though. It is a PDE3 inhibitor. It is used for short-term use for decompensated heart failure. It can cause arrhythmias and hypotension. I think Milrinone, I'm trying to remember the specific, I'm getting this correctly. Milrinone, it says it in vascular smooth muscle increases cyclic AMP, general vasodilation. So it should cause both dilation of the arterioles and the venous system as well. It does both, I believe. What about lipid-lowering agents? Here we go. And you have the same diagram that I have as well, right here, which should hopefully be of some use to you. So if I were you, I might take a screenshot of that or pause the video and take a snip of it or something like that, and just save that to your notes if you want to use it. Anyway, lipid-lowering agents. Drug, LDL, HDL, triglycerides, mechanism, adverse effects. So statins, which are also called HMG-CoA reductase inhibitors, like atorvastatin, lovastatin, pravastatin, rosuvastatin, and simvastatin, they significantly reduce LDL. Remember, LDL is, I believe it's called low-density lipoprotein, and HDL is a high-density lipoprotein. Remember, HDL is the kind of cholesterol that you kind of want to have around because it's going to be taking the cholesterol from the periphery and bringing it back to the liver. While the LDL is the quote-unquote bad cholesterol, which is trying to distribute cholesterol. Now, of course, HDL is not like this sort of conscious, aware do-gooder, and LDL is this some sort of villain necessarily. It's not malicious. It's just that LDL distributes cholesterol around the body, and HDL tries to remove it from the periphery and bring it back to the liver. And so as a consequence, if you are worried about atherosclerosis, you want to remove a lot of those lipoproteins and those fats and all this cholesterol away from the periphery and bring it back to the liver because it's going to make you less likely to have plaques build up. And so we want to have HDL around to kind of manage that, kind of bring the cholesterol out of the periphery. We want to keep that LDL to a minimum so it's not distributing that much fat and cholesterol across the body. I should say not that much. We want to avoid distribution is what I'm trying to communicate, basically. We're trying to avoid distribution. We're trying to encourage bringing it back to the liver. So anyway, LDL, statins cause a significant reduction in LDL, and they cause some modest increase in HDL. They cause a decrease in triglycerides. The mechanism inhibits the HMG-CoA reductase, which is going to cause a decrease in cholesterol synthesis, because again, that's the conversion of HMG-CoA into, I think, mevalonate, which is mevalonic acid. And that's one of the major steps, I think it's the rate-determining step in the process of synthesizing cholesterol in the body. So if we inhibit that, you will have a decrease in cholesterol synthesis, a decrease in intrahepatic cholesterol, an increase in LDL receptor recycling, and an increase in LDL catabolism, with a decrease in mortality in patients with CAD. The adverse effects, hepatotoxicity, lead to an increase in LFTs, myopathy, especially when used with fibrates or niacin. Bile acid binding resins, or bile acid resins, cholestyramine, cholesevelam, and cholestyramine. These cause a significant or meaningful reduction in LDL, a slight increase in HDL, a slight increase in triglycerides. These disrupt enterohepatic bile acid circulation, leading to compensatory increase in conversion of cholesterol to bile. This leads to a decrease in intrahepatic cholesterol, which leads to an increase in LDL receptor recycling. The adverse effects of bile acid resins, though, would be GI upset, right? You're preventing the absorption. So as a consequence, you have some GI upset. Decreased absorption of other drugs and fat-soluble vitamins. So the fat-soluble vitamins are A, D, E, and K. vitamin A, vitamin D, vitamin E, vitamin K, and they are fat soluble, which means you use fat to help absorb them into the body. And so if you have something that's preventing fat absorption, which is what bile acid binding resins are doing, well, then not only will you have GI problems because you aren't absorbing the fat, but you're also going to have a difficulty potentially in absorbing those fat-soluble vitamins in the first place. Ezetimibe will decrease LDL meaningfully. It'll either increase or have no effect on HDL. It'll either decrease or have no effect on triglycerides. The big thing is this: ezetimibe decreases the LDL. Ezetimibe prevents cholesterol absorption at small intestine brush border. Okay. And it causes an increase potentially of rare increase in LFTs or diarrhea. Again, that's not really surprising. Again, ezetimibe and bile acid binding resins are affecting the GI absorption of basically lipids, cholesterol in the case of ezetimibe anyways, and so they might have some sort of GI effects, as you can imagine. What about lipid-lowering drugs? I talked about lipid-lowering agents, now we're talking about lipid-lowering agents continued. Okay, fair enough. So this is page 2 for me, but it's all the one thing for you. So fibrates, fenofibrate, gemfibrozil, and your thing has an old one called bezafibrate. I don't know how much they talk about that one anymore, but they talk about gemfibrozil and fenofibrate still. You have a decrease in LDL, an increase in HDL, and a major decrease in triglycerides. How does it work? Well, it activates PPAR alpha, which upregulates LPL, which I think is lipoprotein lipase or something like that, which increases the triglyceride amount clearance. So that increases the clearance of triglycerides. They activate PPAR alpha, which induces HDL synthesis as well. Adverse effects: it can cause myopathy, which with increased risk with statins. Cholesterol gallstones via the inhibition of cholesterol 7 alpha hydroxylase. Okay. What about niacin? Niacin causes a meaningful decrease in LDL, a meaningful increase in HDL, and a decrease in triglycerides. The mechanism is it inhibits lipolysis, hormone-sensitive lipase, in adipose tissue, reducing the hepatic VLDL synthesis. Remember that VLDL is very low-density lipoprotein. Okay, I wanted to confirm LPL from before is lipoprotein lipase. Back to niacin. Niacin can cause flush face, prostaglandin mediated by decrease in NSAIDs or long-term use. And niacin can also cause hyperglycemia and hyperuricemia, which is interesting. PCSK9 inhibitors like alirocumab and evolocumab, those significantly decrease LDL, which is interesting. They increase HDL, okay, and they decrease triglycerides. Okay, I was confused for a moment. Okay, yeah, no, LDL, we want to decrease LDL, yeah, so it causes a significant decrease in LDL, good. So how does PCSK9 inhibitors work? Well, they inactivate the LDL receptor degradation, which increases the removal of LDL from the bloodstream. So I don't think it describes exactly how the mechanism works here. Might have to look at the diagram. Let me show you the diagram for a moment. So maybe it describes a little bit better detail here. But there's basically a molecule. Oh yeah, I guess a molecule is PCSK9. They don't say it, but that's what it is. PCSK9 basically breaks down or degrades, making ineffective the LDL receptors. Or is it the LDL receptors? It's the what is it called? They say LDL receptor. I would say HDL receptor, but they say LDL receptor degradation. So just accept that. There's LDL receptors on the liver that's going to take up these LPL, these cholesterol stuff in the body. And the more of them that you have, the more capable the liver is able to uptake all this stuff. However, there's something called PCSK9, and that'll break down or degrade those receptors. And so if you have something called a PCSK9 inhibitor like alirocumab or evolocumab, well, that's going to prevent that from happening, so you will have more receptors and have more uptake, which is what you want to have happen if you want to reduce your LDL. These things can cause, though, myalgias, delirium, dementia, and other neurocognitive defects, so not exactly so fun on that front. We also have fish oil and marine omega-3 fatty acids. These can slightly increase LDL, slightly increase HDL, and at high doses they can decrease triglycerides. So basically, they're not super effective, but they have some impact on these processes, obviously. I mean, you're absorbing a bunch of fatty acids, of course it's going to have an impact on cholesterol potentially. It just isn't as significant as you might think. These are believed to be a decrease in free fatty acid delivery to liver, decreasing activity of the triglyceride synthesizing enzymes, decreasing VLDL production, and inhibiting the synthesis of ApoB. They can cause nausea and fish-like taste. So, it's basically a situation where it's not a whole lot of danger to yourself if you take fish oil, but it's also not necessarily super beneficial. So drugs would definitely be a lot more effective typically, but they also can have more complications, and obviously there's basically a risk-reward situation, but realistically speaking, you're not going to get a major benefit, like a categorically completely different benefit if you take something like fish oil. So here's a diagram showing a lot of the things we're talking about before: cholesterol synthesis. We're talking about PCSK9 inhibitors, niacin, fibrates, bile acid binding resins, so forth. Again, I would definitely look into that. These diagrams are very useful for understanding how things work and how they're part of a bigger picture, essentially. We're close to done. We're wrapping it up. We're on 326. Remember, we wrap up on 328. Well, in that case, it looks like I just turned off the volume of my computer rather than turning off the audio, but it doesn't really matter. The digoxin. Do we have anything on digoxin here? I don't know. Well, they have digoxin right here, yeah. They say cardiac glycosides, and their entire list of cardiac glycosides is just digoxin. That's it. Mechanism of digoxin: direct inhibition of sodium-potassium ATPase, leading to an increase in indirect inhibition of sodium-calcium exchanger. This has an increase in calcium, leading to an increase in positive inotropy, which stimulates the vagus nerve, leading to a decrease in heart rate. And you can see the diagram showing there, it's kind of this indirect method of trying to get that increase in calcium intracellularly, to increase that inotropy, that contractility. So what is it used for? It's used for heart failure, to increase the contractility for that. They use an AFib, atrial fibrillation, to decrease the conduction at the AV node and depression of the SA node. Adverse effects: cholinergic effects, nausea, vomiting, diarrhea, blurry yellow vision, Van Gogh, okay. Arrhythmias, atrial tachycardia with AV block. Can cause or can lead to hyperkalemia, which indicates a poor prognosis. Factors predisposing to toxicity include renal failure, which decreases the excretion, hypokalemia, permissive for digoxin binding at potassium binding site on the sodium-potassium ATPase, drugs that displace digoxin from tissue binding sites, and decrease in clearance, for example, verapamil and amiodarone and quinidine. Is there an antidote for it? Well, yeah. Slowly normalized potassium, cardiac pacer, anti-digoxin Fab fragments, and magnesium. Okay. And magnesium, if I'm not mistaken, is another one of these atypical antiarrhythmics. That's a class 5 antiarrhythmic, I think, magnesium, because it has it doesn't really neatly fit into classes 1 through 4. Along with digoxin. Digoxin is also a class 5. It's an atypical antiarrhythmic. Okay, here we go. Antiarrhythmics, sodium channel blockers, class 1. And class 1, we're talking about class 1, class 2, class 3, class 4, and then they have this thing called other antiarrhythmics, which includes the magnesium that I was talking about before, as well as adenosine. So, and also they talk about ivabradine, which is maybe its own little thing, separate from the classes. Remember that the atypical antiarrhythmics, like magnesium, those are class 5 technically. Let's talk about antiarrhythmics. Sodium channel blockers, class 1. Slow or block conduction, especially in depolarized cells, decrease slope of phase 0 of depolarization, increase action at faster heart rate, state-dependent increase in heart rate leading to a shorter diastole, Sodium channels spend less time in resting state. Drugs dissociate during this state. Less time for drug to dissociate from receptor. Effect most pronounced in IC more than IA. Okay, sorry. The effect most pronounced in class 1C greater than 1A and then 1B. So 1B is the least. 1C is the greatest. So due to relative binding strength. So fast, taxi, cab. So cab, CAB is the order in terms of the effect, how pronounced the effects are. Okay. So class 1A, you have quinidine, procainamide, disopyramide. The queen proclaims disopyramide, or you could say whatever you want to do. I've heard before the queen is disappeared, right? Disopyramide. So let's just read through it. Mechanism for class 1A sodium channel blockers. Moderate sodium channel blockade, increase in AP duration, increase in effective refractory period, ERP, and ventricular action potential, increase in QT interval, some potassium channel blocking effects. Clinical use, both atrial and ventricular arrhythmias, especially reentrant in ectopic SVT and VT. Adverse effects, synchronism, which is headache, tinnitus with quinidine, reversibles, lupus-like syndrome, procainamide. Remember, procainamide, like lupus. Lupus is a wolf. Procaine, like canine. Heart failure with disopyramide. Thrombocytopenia, torsades, due to increase in QT interval. Okay, and look at how the presentation is for class 1A for that show for showing the slope and stuff like that. Be aware of that as well. Class 1B, lidocaine, mexilatine. I'd like to buy Liddy's Mexican tacos. Okay, whatever. Lidocaine and mexilatine. Those are class 1B. Mechanism. Also, there's a good set of sketchy videos on these classes of drugs as well. That's useful. Anyway, mechanism class 1B. Weak sodium channel blockade. Decrease in AP duration. Preferentially affects the ischemic or depolarized prekineate and ventricular tissue. So they're basically focusing more on the ventricular region as opposed to the supraventricular area. It's the below part of the heart, you could say. Clinical use, acute ventricular arrhythmias, especially post-MI, digitalis-induced arrhythmias, IB is best post-MI. So 1B is best post-MI. Okay. Adverse effects of 1B drugs, CNS stimulation / depression, cardiovascular depression. Okay. And now we'll see class 1C. See the difference between class 1A, 1B, and 1C for the diagram? How the slope looks like. B is a lot more, B is a lot less exaggerated, a lot more minute compared to A and C. Let's talk about class 1C. Class 1C, flecainide, propafenone. Can I have fries, please? Okay, whatever you want to, whatever floats your boat. Mechanism for class 1C sodium channel blockers. Strong sodium channel blockade significantly prolongs the ERP and AV node and accessory bypass tracts. No effect in the ERP in prekineate and ventricular tissue. So it's very heavily on the upper part of the heart. Well, B is very focused on the lower part of the heart. It has minimal effect on AP duration. And I just want to say also, again, I do this a lot, but I just want to make sure that I'm not missing anything, and I guess by proxy that you're not missing anything. ERP refers to the effective refractory period. Okay, that's the kind of like how wide that plateau from the beginning of the depolarization to that period all the way down to repolarization, that gap between the two, that's called the ERP, the effective refractory period. Okay, clinical use of class 1C sodium channel blockers. SVTs, including the atrial fibrillation, only as a last resort in refractory VT. I assume that's ventricular tachycardia. Now, the thing is with this should make sense to you because class 1C is super focused on supraventricular issues, things that are above the ventricles, the upper part of the heart. And so unsurprisingly, they're good for supraventricular tachycardias. Compare that to class 1B, for example, which is very focused on the ventricular region. What is it used for? It's used for acute ventricular arrhythmias and digitalis-induced arrhythmias. So basically, it's the best for post-MI. So class 1B, very ventricular focus. Was it good for ventricular arrhythmias? What is class 1C focused on? Supraventricular region above the ventricles. What is it good for? Supraventricular tachycardia. So that should make sense to you. Adverse effects for class 1C anti-sodium channel blockers would be it's pro-arrhythmic, especially post-MI, so it's contraindicated for MI, post-MI anyways. Class 1C is contraindicated in structural and ischemic heart disease. So for 1C, you don't want to use it for post-MI, but for 1B, again, which is kind of like the opposite, you do want to use it for post-MI. Potentially, right? Now, what about antiarrhythmics that are beta blockers? These are class 2 antiarrhythmics. We've talked about beta blockers before. We'll go into some detail here as well. We have metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. So they have that lol suffix. Mechanism of beta blockers: they decrease the SA and AV nodal activity by decreasing the cyclic AMP and decreasing the calcium currents. They suppress abnormal pacemakers by a decrease in slope of the phase 4. AV node particularly sensitive, leading to an increase in PR interval. Esmolol is very short-acting. Clinical use: supraventricular tachycardia, ventricular rate control for atrial fibrillation and atrial flutter, prevent ventricular arrhythmia post-MI. Adverse effects: impotence, exacerbation of COPD and asthma, cardiovascular effects like bradycardia, AV block, and heart failure, CNS effects like sedation, sleep alterations, may mask the sign of hypoglycemia. Yeah, true. Metoprolol can cause dyslipidemia. Propranolol can exacerbate vasospasm and vasospastic angina. Beta blockers, except the non-selective alpha and beta antagonist carvedilol and labetalol, can cause unopposed alpha-1 agonism if given alone for pheochromocytoma or for cocaine toxicity, unsubstantiated. So basically, we don't know that's true, but we would think it maybe is true. So we just kind of we just take safe precautions, I guess, even if we don't have good evidence otherwise. We're just kind of erring on the side of caution rather than the side of danger, perhaps. Treat beta blocker overdose with glucagon, atropine, and saline gas. So glucagon, atropine, saline. You can treat beta blockers with those. Glucagon is pretty obvious. It's a pretty well-known one, I would say. At least that's more well-known to me. But atropine and saline can also be useful. There's a little graph right there as well for showing class 2 effects. And finally, we're on our last page, which is page 328 for the cardiovascular section. But we're not done quite yet, of course. We still have that page. Antiarrhythmic potassium channel blockers. These are class 3. Amiodarone, ibutylide, dofetilide, and sotalol. AIDS. Okay. Mechanism of class 3. These are potassium channel blockers, by the way. Increase in AP duration, increase in the ERP, which again we said that was, what was that again? Effective refractory period, right? Yeah, effective refractory period. So, increase in effective refractory period, increase in AP duration, which is action potential, increase in QT interval. Clinical uses: atrial fibrillation, atrial flutter, ventricular tachycardia, amiodarone, sotalol. Adverse effects: sotalol causes torsades, excessive beta blockade. Ibutylide causes torsades. Amiodarone causes pulmonary fibrosis, hepatotoxicity, hypothyroidism, or hyperthyroidism. Amiodarone is 40% iodine by weight. Okay. Acts as a hapten, corneal deposits, blue-gray skin deposits resulting in photodermatitis. Neurological effects: constipation, cardiovascular effects, bradycardia, heart block, heart failure. Remember to check the PFTs, LFTs, and TFTs when using amiodarone. Amiodarone is lipophilic and has class 1, 2, and 3, and 4 effects. So, I think there's another one of these class 3. There's another drug that has multiple effects from different classes, but I think amiodarone is the one that has effects, again, from all 4 classes. It's also lipophilic, which is interesting. Okay, so that's what that looks like for class 3. Pay attention also to the cell action potential that they're showing here. showing a markedly prolonged repolarization. And finally, class 4, antiarrhythmics, which are calcium channel blockers. These are diltiazem and verapamil. Those are non-dihydropyridine calcium channel blockers. Mechanism: decrease the conduction velocity, increasing the ERP, increasing the PR interval. The clinical use: rate control in atrial fibrillation or flutter, the prevention of nodal arrhythmias. The adverse effects of them: constipation, gingival hyperplasia, flushing, edema, cardiovascular effects, heart failure, AV block, sinus node depression. And you can see here the slow rise of action potential and the prolonged repolarization of the AV node. And then we go into other antiarrhythmics. That would be, I think, a class 5 in a certain sense. Adenosine, increased potassium out of the cells, leading to hyperpolarizing the cell and a decrease in the ICA. Is that intracellular calcium? I'm not sure. Decreasing the I would assume, but I'm going to look that up if you want to. Decreasing the ICA, eye calcium. Decreasing AV node conduction, drug of choice in diagnosing/terminating certain forms of SVT, very short acting, 15 seconds, effects are blunted by the theophylline and the caffeine. Both are adenosine receptor antagonists. Adverse effects include flushing, hypotension, chest pain, sense of impending doom, bronchospasm. Not so fun. Magnesium is effective in torsades and digoxin toxicity. Ivabradine mechanism: IV abradine, prolonged slow depolarization, phase phase 4. Sorry. Ivabradine, prolonged slow depolarization, phase 4, by inhibiting funny sodium channels. Oh, okay. Funny sodium channels. So those are calcium channels before. So when they say ICA, they mean calcium channels. I would assume that's what they mean. I would assume. Clinical use of ivabradine. When they say ICA, that probably means the calcium channels. They're referring to that. But anyway, back to ivabradine. Ivabradine, again, that's going to selectively inhibit the funny sodium channels. Clinical use would be the chronic heart failure with reduced ejection fraction. Adverse effects of ivabradine would be luminous phenomena / visual brightness, hypertension, and bradycardia. Oh. Okay, there we go. And that concludes our chapter for cardiovascular section. We did basically the pathology and the pharmacology of the cardiovascular chapter, and we covered the other sections in our previous live stream. If you got through this entire video, well, hopefully it was of good use to you, and thank you for watching.